Thank you so much for attending the Child Abuse Investigation Task Force. Today is September 26th. It is approximately 11:15, and we are getting ready to officially get started. I do want to kind of give a few ground rules. I'm going to ask everyone to please silence their phone. If you're here to give public testimony, I'm going to ask, certainly that we want to hear from everybody, but we want to be sure that whatever part of your testimony does not violate the privacy rights of children. I also want to ensure that parameters as it relates to what can and will be actually allowed to be shared so that it does not actually conflict with any parts of the law. While we also welcome public testimony, I want to be really clear that I do not want any testimony to identify a child victim or provide public graphic details of alleged abuse. We do not want testimony that deframes or disparages individuals by name who are parties to litigations, members of the judiciary, DCFS workers, etc. We have stated repeatedly these parameters, and we want to ensure that they will be actually adhered to today. Lastly, I would like to remind everybody of this as we start the public testimony component, which is at the end. I will ask Ms. Peck to help keep us on track and to make sure that we stay focused and make sure that we are protecting the identity of the kids as we talk about the issues that they actually may have encountered. At the end of the day, we want to make sure that we hear from everyone that would like to testify, but we want to make sure that we have parameters in terms of how that is done in the proper manner. With that stated, I will officially call the meeting to order. I'm going to ask for roll call, if you would please.
Senator Barrow.
Present.
Present. Dr. Birch. Present. Honorable Green. Present. Ms. Hadley. Present. Mr. Hanneman. Present. Dr. Hook. Present. Ms. Moody. Present. Captain Patu. Present. Honorable Russell. Present. Ms. Shelton. Present. Captain Sanji. Dr. St. Germain. Present. Dr. Thurber. Ms. Wascom. Present. And Honorable Womble. Present. We have 13 members present.
Great, thank you. And I want to thank all of the members for being here today. We greatly appreciate you taking our time to be here to share and be a part of this very important task force. At this time, I'd like to ask for approval of the minutes. They should be inside of your folder. If we may have a motion to approve the minutes. Moved by Honorable Russell and second by Honorable Green. Okay, so it's my understanding, I know that we have some physicians here. We have a lot today to cover, and we know that we have a very tight schedule, and so we want to really, first of all, I want to appreciate everybody for taking their time to be here, but we really want to respect your schedule and your time. And so at this time, give me 1 second. Okay, at this time, we're going to ask for the physicians or doctors from the hospitals, if they would all come forward. I know that we have the lake here. Who else do we have? Do I have cards? Have y'all filled out cards? Okay. Rooms. So we have Dr. Pontiff.
That's me.
Did I pronounce that correctly? Okay. Dr. Mahady?
Meta.
Meta?
Yes.
Okay. And Rachel Morgan. Same nurse. Okay, if you will all come up together. All right, great. Thank you so much for being with us today. And so we're going to start from my right and your left. And if you would introduce yourself and give us your testimony.
Hi, my name's Kristen Poniff. I'm a physician at our.
Pull the mic a little closer to yourself.
Is that better?
That's better.
Okay. My name's Dr. Kristen Pontiff. I am a physician at Our Lady of the Lake Pediatric Emergency Department. I'm also the director of the emergency department at Lake Peds. I've been in that role for about 2 years now. I am here this morning to give some understanding and clarity around the process of receiving and evaluating patients that come in under the complaint of assault of some particular kind. Our hospital has a process that they follow when these patients present to our waiting room. And so if there is a concern about any kind of alleged assault and or abuse, that is noted in our triage documentation, and then in our normal kind of situation, a physician, a social worker, if they're present at the time on campus, and the nurse go in together to have a conversation with the family and the affected child in order to gather information and then distribute that to the appropriate organizations. Typically, we are consulting DCS, police department, at the time of child presentation. And then we send a referral to the Child Advocacy Center, which is a paper form that we use at the hospital that comes in with families' information, patient information, those kind of things. And then this gets faxed to the Advocacy Center. So they have all of that information and are able to follow up with families to set up further needs. A lab.
Excuse me, do you have a copy of that we can, okay, sure. Thank you.
And then we make decisions together related to lab work, physical examination. If the same nurse comes out because there's concern for alleged sexual assault, we have a communal conversation with them related to being able to group the physical exam and lab and other things together, so that way we are not causing any further stress and or distress to family and participants in this obviously very charged visit. And then after those pieces are completed, we have a conversation with DCS, we have a conversation with police. We determine a safety plan for the child. Is the family deemed safe by DCS and other departments to be able to receive the child home? And if that's the case, then we discharge them with those follow-up things that I mentioned in place.
Okay, all right. And so I don't see any questions at this time. So what I'm going to do is let each one of them speak, and then we'll have questions. Dr. Mehta?
Good morning. Dr. Neha Mehta, I'm a board-certified child abuse pediatrician. I'm the medical director of the child abuse program at what was formerly Children's Hospital New Orleans, now Manning Family Children's. And so when children present to the emergency department, they are evaluated. A determination is made if there is a need for evidence collection, or if this is a case where it is believed that the abuse is more chronic and not recent. Mandated reports are made. We have social work coverage 24/7. And so a trained social worker meets with the family, obtains the appropriate reporting data, and contacts the agencies that are involved. And if there are safety concerns, follows through to see if the child is considered safe to be discharged home by the Department of Child and Family Services. All children who present to the emergency department at Manning Family Children's are then referred to a subspecialty program that is unique to our facility, where specially trained pediatric physicians trained in child abuse, as well as nurse practitioners, then do a more detailed evaluation of the child in speaking with the child, making sure that all global needs have been met. And we're also able to relay that information to any investigators. We work collaboratively with about 7 child advocacy centers in our region, and so we of the medical program for approximately 7 child advocacy centers in sort of southeast Louisiana, serving probably about 18 parishes.
Okay. And I'm sorry, I don't see your card. Did you fill out a card? Okay. So you are Miss Morgan. Okay, Miss Morgan, and you are a SANE nurse.
Yes, ma'am.
Okay, would you introduce yourself?
My name is Rachel Morgan. I'm a registered nurse with specialization in SANE nursing, which stands for Sexual Assault Nurse Examiner. So our role in this is when a child presents to a hospital with a complaint of sexual assault, we're dispatched out to the hospital. Ages 12 and under report to Our Lady of the Lake Children's Hospital here in Baton Rouge. 12 and over can go to other hospitals in the East Baton Rouge Parish area. We go to them, other hospitals being Lane Regional Medical Center as far out in Zachary, and then any other, hospital in the Baton Rouge city limits. So if the patient lives outside of that, they come to us inside the area that we serve. Whenever we get there, our first thing that we do is, of course, have a conversation with the physicians and the nurses that are caring for the child. We do collaborate after that. If the child is, old enough to consent, to a handwritten consent, we do that. We practice the rule of thumb, consent and assent. So at any time the exam is stopped, at any time the child is not comfortable. If from there, our job is then to assess the child head to toe. So literally from the top of their head to the bottoms of their feet, looking for any injury that's not age appropriate, anything that wouldn't be just normal scratches, bruises, falls, and stuff like that. After that, then we do photography. So we always start with the face, and then anything that we may find along the way, we take a picture of it in 3 different angles and measure as well, all the way down. And then whenever we get to the genitalia part, because we're here for sexual assault only, we don't serve physical assaults, only primary physical assaults. Whenever we get to the genitalia, we always do photography there, whether we see signs of injury or not. And the purpose of that is so that I can then take my camera back to the office, put it on a wider screen, zoom in, and at that point, many times I'm able to see like microabrasions that you can't capture just with the naked eye. So that happens. There's a few different specifications for age-related, with children. So if a child is prepubescent, the focus is on external genitalia, meaning meaning nothing is inserted into the vagina, into the anal opening. If the child has reached puberty, then we can do internal, evidence collection swabs. The last step of our procedure is then evidence collection. So starting with the mouth and then swabbing various parts of the body according to the child's story, external and internal. We do practice with a pretty tight time frame, which is kind of like holds us, constrains us a little bit. We're only called out for sexual assaults that have occurred within the past 120 hours. And then primarily because our main goal is evidence collection, right? In the pediatric population, because most assaults are not penile vaginal penetration, and we're focused on external genitalia, in the pediatric population, meaning 12 and under, really our time frame to collect forensic evidence is 72 hours or less. So it is a tight window. If the child doesn't meet that time frame, because we know that, children's stories are not always, their concept of time may not be quite accurate, so we are allowed to kind of wiggle outside of that time frame. But if they are too far outside of the time frame, the child is then deemed to be like a chronic case, and then they'll be referred to, like the Audrey Hepburn Center or something like that in New Orleans.
Okay, so I don't see any questions, but I know that I have a couple. So do y'all have like categories in terms of how certain things are actually administered? If, say, for infancy through maybe 3, 4 through 6 or whatever, are there categories in terms of things that are actually done for certain ages, or do pretty much every age go through the same process? Because you said something about consent, and so consent, I'm thinking 18, but tell me what that means in your,
So if the
vocabulary.
child is 12 and under, of course, the parent
Okay.
has to consent and the child assents, you know. If the child is of the age, you know, if you're dealing with a 16-year-old or something, you know, they can decline a sexual, you know, exam. They can decline that. Even though it might be the parent's wish, they're old enough to say, no, I don't want this. Doesn't mean they're not treated by the hospital. And then, of course, a conversation would be had with law enforcement.
so stop right there. So a 16-year-old who may been assaulted, the parent may actually ask for it to be done, but the child can say no?
We're never going to hold a child down to collect DNA evidence. At that point, risk versus benefit, you know, re-traumatizing the child. And you know, for as long as I've been doing that, we've never had that. Most of the time, they're just too scared to say yes. And after we talk them through the process and say, you know, this is what we're going to do, just these 3 things Miss Rachel has to do with you, then they're okay. I've never had a child,
Okay,
you know,
okay.
not want to follow through, if that makes sense.
Yes, that makes sense. Okay. So are there certain things that are done for infants that may not be done for older children? Just the process in terms of what is actually,
The process for a prepubescent child who's not reached puberty is different than the
Okay.
process of an older child, meaning internal forensic DNA evidence is only collected for a child who has reached puberty.
Okay.
If the child is 12 years old, that's a good standard. You know, of course, not every 12-year-old is the same, but that's a good objective age to where, you know, puberty is reached or may not have been reached. If the child is younger, let's say a 3-year-old, we're not going to insert swabs to collect DNA on the inside of the vagina because, of course, the risk of injury is greater than the benefit of collecting DNA. We just focus on the outside.
okay,
Does
and
that
then,
make sense?
okay, sorry. This question could be for any of you. So have any of you actually made a recommendation that DCFS get involved, or that this needs to be taken to a higher level in terms of maybe law enforcement, and maybe they did not agree that it needed to be done? Has that ever occurred, that you thought that it needed to be escalated to, it needed to be investigated or looked into a little bit further, and maybe it was determined that maybe not?
We, at Manning Family Children's, we do dual reporting, so we do not rely on one agency to determine if the other agency needs to be involved. So we're going to report to both agencies, and then they make their own internal determinations as to what they do. But we do not, at our agency, request that Child Protection determine if law enforcement should be involved or law enforcement determine. We're going to make those reports. We will know that if the alleged offender is not something that would qualify for a DCFS investigation, such as a teacher or a coach or something that would be out of their purview, then we would not report to DCFS. But if it's an in-home concern, then we would co-report to both agencies, and then those agencies pick up the ball from there and determine what their processes are.
And once you guys do that and it's turned over to them, do y'all receive any notification in terms of like, yes, we have it, it's being investigated, or anything of that sort?
The person who makes the report does not.
Okay.
Within the systems, it can happen. So, for example, if a child went to our emergency department, reports were made, and, for example, the child was served by one of the parishes that we work with, particularly Orleans, for example, then in a multidisciplinary team meeting that the CAC would have, a medical person is present. And so, for example, I would be present to hear about what happened with the case for an Orleans case, and then I have colleagues who would be present for St. Tammany or other parishes.
Okay.
But not 100%, not the medical person. We don't, it would be the Child Advocacy Center that would get
But there is some level of follow-up or some
through the Child Advocacy Center.
through the Child Advocacy Center. Okay. Dr. Hook.
Yes, I was wondering, for the task force, would you all be able to talk a little bit about the absence of findings, and in the event that there aren't physical exam findings, what would that mean? Or what could that mean?
So the vast majority of children who report sexual abuse, even when they make a very credible report, or it's eyewitnessed, or there is videotaped evidence, still have normal exams. And so most children are not going to have a visible finding on physical exam, despite a very believable and authentic report of abuse, even reports of abuse that sound like they could have been penetrative. This is a very common myth in society, and so many times families come to an emergency department believing that they're going to get the answer right then and there as to whether their child was abused, and they're often struggling with the fact that the medical staff is saying, this exam is normal, which is good news for your child, but we're not able to exclude child sexual abuse. It is so prevalent a myth that this is something that we routinely are asked to talk to not only parents about on a near daily basis, but even judges, juries, law enforcement, et cetera, because it is such a common belief that you can look at the genitalia and determine something. And since the majority of children do not disclose sexual abuse within that 3-day time period, if it is within that 3-day time period and evidence can be collected, that's great. But the majority of children's disclosures occur sometime later when they feel safe and they're able to disclose about prior abuse.
Wow. Okay. Senator Hodges.
On. Well, you answered my question, I believe, in that case where it was past the window of the 72 hours because children have a lot of shame and confusion about it. So it is going to be, in many cases, later. So what is the process for DCSF in that case if there's been repeated allegations of the child that are believable, but it's past that window? Then what's the process for that with your institution and law enforcement?
If the child presented to the emergency department, then those mandated reports would be made to those agencies, and then that would be passed on to them. So we also have that subspecialty program, and so at least in our community, if there is concern that anyone has about child sexual abuse, our medical program has no barriers to families. Families can self-refer. Law enforcement can send them. Pediatricians in the community can send them. And so it is an opportunity for a more detailed medical evaluation for children when there are concerns of abuse. But we would then again be making reports to those agencies, and then questions about what would be done within those agencies, I would defer to their expertise.
Okay, so walk me through the process. You file a report.
But we
give it
file a report.
to DCSF and law enforcement, and then what happens after that?
I will seek to determine if the investigation has been assigned to somebody so that I can send them a report with regard to that evaluation. In some cases, if we're going to verify that the case has been accepted by at least one of those two agencies, if there is a concern for abuse. And so at that point, it's often the first response is usually law enforcement that sends somebody right away. So we are able to make a report to that person. But how our reports get triaged within other agencies, I would not be able to comment on.
Okay, well, that's what I would like to know, what happens after that. So thank you very much for what you ladies are doing and what you're doing to help children. Thank you, that's all.
Thank you, Senator Hodges. Ms. Shelton.
I have a question about the safety assessment. I believe you both said DCFS is involved when you do the safety assessment for the child. Can you walk us through that process? Who contacts them, and then how does that take place?
Yes, so in our emergency department, we're working as a team, and so sometimes physicians will call out to the hotline and have a conversation, and we file a report, and then it is reviewed, I believe, internally to decide whether or not immediate assistance is needed based on the details that we provide, that online call number. So it's either, the physician of record, the provider of record, or the nursing staff who can do it, but we're all mandated reporters, and so anybody can perform that task. And then if it is meets criteria for immediate assistance, then we are able to have FaceTime with that worker at the bedside and have a conversation about what our physical examination findings were, what our concerns were, those kind of things, and have conversations surrounding like a generalized safety plan if we are talking about discharging the patient, who they would go home with, and what the idea for that would look like. I can't speak to what internal processes DCS has for looking into things like safety of the home and those kind of things, but there are times where our workers will leave, assess the home, come back and say, okay, the family is cleared for discharge home, or something like that. Or we make alternate plans for like a family member or someone else to take care of the child while other things are ongoing and being investigated in the background.
Is there ever a situation where you felt like the criteria was met and someone should have given immediate assistance and someone did not show up from the department to help with the safety assessment?
I would say that has happened in my time here, but I feel like there have been some transitions within that organization that have stopped that from happening as frequently as I felt like it used to.
Okay. And is there anybody you can call above?
Yes.
Okay, you do have a contact
Yes.
with the department?
Yes.
Can you just share with us who it is?
Becca Hook. Yeah, she's up there.
Thank you.
Thank you.
Thank you, Ms. Shelton. Dr. Birch. It's so sensitive. Okay.
Thank you. Actually, I think you guys have touched on a lot of my questions. It was really about what your experience is like handing off to other agencies. And I think the one thing I haven't heard about is response times in terms of like making reports and having a response to a family to come out and do that safety assessment.
So I can speak to our ER. It varies and depends. Obviously, time of day is going to be a huge factor, and a lot of families. We live in a town where a lot of people do shift work and those kind of things. So our emergency departments are busy at nighttime. We have off hours where these presentations are happening, and so sometimes it takes a little while for all of the moving pieces to be aligned. But again, I feel like with reorganization within DCS, we've had an improvement in our response times. Also, to just kind of speak to the fact that I think every department that gets involved with one of these cases is obviously very concerned and wants to do the most within their means, but sometimes resources are limited. And so I think every facet, every organization that we get involved with this is doing the best they can with what they have. And so oftentimes, if we're calling police departments in Bachelor, Louisiana, which I didn't know where that was until last night, but that police department is sending someone out to take a face-to-face report with this family because they understand the urgency of what's going on. And so yes, there are longer wait times for certain things, but I think we're doing the best that we can, and I think that all of the parties involved understand that there's a need that needs to be met.
So on average, what would be the time frame that you would say, average time?
It depends on where your patient is coming from and what police department the alleged occurrence is happening within. So if we're talking a patient getting transferred from 2 hours away, then we're talking about a couple of hours for that to happen.
So you
again, it
say
just
within a
depends.
24-hour period, though?
Yeah.
Okay.
I would agree with that. I would say within a 24-hour period is a good guideline for when there will be a response. And then I know that there's been a movement, at least locally, for us to have increased presence of DCFS on different shift times. And so I think that issue is a real issue at 10 o'clock at night. What is the availability of a person to come and make a determination about the safety of a child? And so I think some of that is work in progress in terms of being able to improve that wait time. I also know that sometimes if a family comes from very far away, they will ask for a courtesy report by a local agency. So they might ask, for example, NOPD to respond, or Orleans Child Protective Services to respond if the parish is 4 hours away, for example.
Have y'all noticed that there are certain days or certain time of the day where there may be a peak that you see more of these cases than others, than any other time, any day of the week or any time
I'm going
of
to
the day?
defer to the expertise of the person who actually works in the emergency department, but just sort of, it seems to be the evenings. I think sort of school's over, people are off work, and it sort of seems to be the time, between, I'll say 5 and 5 PM and 11 PM, that there does seem to be, at least anecdotally, a surge, but I'll defer to her expertise.
I would agree with that assessment. I would also say split home transitions usually happen after a weekend, and so sometimes there is an influx on Mondays, or like earlier in the week because of those kind of custody transitions.
Okay, good. Thank you for that information. Dr. Hook?
Yes, and I was wondering, could either Ms. Morgan or Dr. Mehta give us any information on the number of referrals you all receive in a given, like, calendar year, month, like some type of time frame?
I wish I would have counted that up. I would say myself, so we have 10 PRN as needed, SANE nurses for the East Baton Rouge Parish and outlying areas. And I would say about 100, 75 or so a year, 100. For us, sexual assaults are much higher in the summertime whenever, maybe children aren't supervised as well. And then to go back a little bit to the previous question, so we don't collaborate that much with DCFS, but our collaboration is with law enforcement. After our exam, there's always a conversation had, especially if there's injury for a child. There's always a conversation with law enforcement. So, speaking to go back a little bit with collaboration, like I say, we don't collaborate with DCFS as much. That's the doctors and the nurses, but law enforcement.
Okay, thank you.
I do not have the data for how many present to the emergency department or how many kits are collected in the emergency department. I could probably get that data. With regard to our outpatient clinical program, we evaluate, depending on the year, somewhere between 12 and 1,500 children a year. The vast majority of that is child sexual abuse cases.
How many again?
At least 1,200 up to about 1,500.
Okay, and of those 12 to 1,500, how many of them fall within that window?
Less than, the time frame of an evidence kit being collected?
Yes.
Less than 5%.
Wow, that is very troubling for me.
It is unfortunately one of the realities of child sexual
Yeah.
abuse, and it's what we spend most of our time educating families about, because most people tell their children, if somebody touches you, you need to say something. And sort of abuse has been happening, the child hasn't said something, they feel a lot of guilt and shame because they were told to say something, they didn't, because it's very hard to talk about something when you care about the person,
Yeah.
as opposed to maybe a stranger. And so because of that, since the majority of sexual abuse is somebody the child knows and cares about, the disclosures are generally delayed and not commonly acute. I would say in adolescence that we're more likely to have somebody come forward and say something happened, within the last 3 days when I was at so-and-so's house or something like that. So teenagers are a little bit more likely to have a kit collected, but children who experience sort of chronic interfamilial or inter-family friend abuse do not generally disclose in a timely way.
Right, and even when they do disclose in a timely frame and we, get the opportunity to go see the child, our focus for under 12 years old is, touch DNA that's left on the outside surface. So you can imagine, if you take a bath every single day for 3 days, that's probably no longer present. So even within the 72 hours, there's a significant struggle, a challenge with collecting forensic, DNA evidence.
The science on that is that most of the time, if you're going to collect evidence off of a prepubertal child, it's within 1 day of the contact.
And that's
You're just
not
trying for the next 2 days, hoping to get something. And the clothing of the child and the bedding is actually much more likely to yield forensic evidence. So that's an investigative piece. If a child shows up at a hospital with clothing, we collect whatever clothing they have. That would be standard policy of any sexual assault program or hospital-affiliated program that collects evidence, but it might not be the actual garments the child was wearing. If something happened on Friday and they come in on a Monday, we're collecting Monday garments. So it would be up to an investigator to find the Friday garments.
Okay, I'm gonna ask you guys another question after Ms. Wascom. Dr. Wascom.
I had a question about the dual reporting, that you said if it's not like someone that they live with, like if it's a coach or a teacher, you only report to law enforcement.
That is correct. Department of Child and Family Services, they only accept cases under certain parameters. And so they take cases where you're concerned about a licensed daycare or an in-home abuse or a home the child is regularly found in. They do not investigate schools or neighbors or other contacts that can occur for children, but that's not within their mandate or purview.
In your discharge from the hospital, is there additional information that's given in the case that it's not referred to DCFS? Like for resources outside of, outside of law enforcement?
So at our hospital, all of those children are going to be referred to our specialty medical program, and part of our practice is we utilize case management with the goal of referring children and families to trauma-informed services. And all child advocacy centers are going to have that as part of their accreditation. They're required to have a plan for services for children as well.
But if it's not within DCFS, I guess my question is, if law enforcement does not feel like, let me think what I'm trying to say here. I just want to make sure that there's a plan in place for safety assessment for these children, if it's not, if it is a neighbor or someone that still has probably access to the child. Does that make sense?
I think I follow your question.
Yeah.
Hospitals are not allowed to make the safety determination, so I'm not allowed, this doctor's not allowed to go in and say, I don't think this child is safe at home, she can't go home.
Oh, well, right. No,
We
no.
have to defer to an agency, so that safety, unfortunately, then I think falls, if it's a neighbor, falls to the parent who brought the child in.
That's my question.
And that would be, law enforcement would follow through with that, but
Yeah.
I think there is a presumption, possibly, that the parent is protective because they brought the child in.
Okay.
And would be directed, this is a person your child shouldn't be around anymore. But I wouldn't make that determination.
I guess I understand that y'all wouldn't make the determination. I was just trying to figure out if there are gaps that someone could fall through. Specifically, teachers and coaches. So that's my only and that might not be an answer that you can give me.
I'm not able to give you that
Yeah.
answer.
That's all. Thank you.
Thank you, Ms. Wascom, which kind of goes back. I was going to wait to see what you were going to ask before I asked my question to you guys and to perhaps Dr. Hook, because part of what the bill did, my legislation did, was actually kind of changed how that process would be kind of evaluated, kind of taking DCFS in more to actually work more with the hospitals when the children come in. So Dr. Hook, I guess I'm going to ask you first, and then I'm going to see if any of that has been actually moving forward, or have we begun to establish what that looks like when the children are brought in the case as when we talk about the caregiver of the child, right? Okay.
Yeah, and so one of the things we probably should bring up is just the recent Act 409. So there are some opportunities now for us to investigate in the school setting, depending on what incident took place. And so if you're not sure about reporting, then it probably is the best practice to dual report in some of those instances as well. So I do want to mention that really quickly. And I do want to let y'all know that we have had 43 alternative responses. And so that was part of Act 409, where we were able to look at child-on-child sexual assault. And we can actually investigate child-on-child sexual assault that occurs in the school place or a school setting. We've only had 2 incidents of child-on-child that we have accepted for investigation. But there have been 41 incidents that were in the home. And before, there was always a little bit of, I think, lack of clarity around our role in child-on-child acts as well. So we should be partnering with you all more to make sure that we're investigating that. That, of course, would have some implications, sometimes of parental culpability, but sometimes it may not be evident. And in those instances, we do want to be involved, at least with a report, and we can decide whether or not we will, accept those for investigation. If there is a reason why we would not, of course, we would we would take that and try to figure out where it needed to go, law enforcement or to another agency. As far as, coordinating directly with the hospitals, we do not have any staff that are working specifically in the hospitals. We are trying to communicate with the hospitals when they reach out to us through our medical team. And so we have there's 3 people on our medical team within DCFS right now. We have a nurse practitioner, and myself. We are trying to build those bridges and establish contacts throughout the state. And people do know that they can contact us through cell phone, email. Most of us are even reachable on the nights and weekends if there is like an emergency that we need to be contacted for. So I'm hoping that is helping with the way that these cases are being investigated and hopefully helping to prevent some of these children from falling through the cracks as well.
So let me ask you this then. Before today, did y'all know were y'all aware of the changes in the Act 409?
Yes.
Okay.
And it's been
I'm sorry. Go
That's okay. It's been updated in our policy and distributed
Okay.
to our providers, and so I think everybody's very aware.
Okay, so,
For reporting child on child, yes. I was not aware about reporting maybe a child and a coach. So that's something I was not aware of. But for child on child, yes. And we're, because that's new for our local Department of Child and Family Services, we've been trying to put together some information regarding how to approach cases where there could be problematic sexual behavior between children and what kinds of appropriate therapies they should be referring children to.
okay. And so typically, because I don't know this, when we change the law to this magnitude, how do you receive that information? Is that done through the association, or is that something that you receive from the department?
I think we received, and I can only speak for my hospital organization. We received it at multiple levels. So like,
Okay.
there was distribution within the hospital, but then I think we also got like a blanket email from the department as well.
Okay.
And so there were multiple like layers.
Okay, okay.
And LHA,
Yeah.
the AAP and LHA also helped us to distribute information across the state to talk about the changes that were being implemented.
Okay.
And I would go back to say that with Act 409, there still is a little bit of it's child on child that we are able to investigate, but there might be people, it expanded the definition of caretaker. So if something were to happen in the home by someone that would not traditionally be a caretaker, such as a neighbor came over to the home, we might be able to investigate that as well, depending on the circumstances around the situation. So it has just expanded the population of people in the community that we are able to investigate by law. And previously, it wasn't so much that the agency did not want to investigate, but we just did not have the authority to complete those investigations.
So that communication has been happening, and you guys are with all the hospitals,
Yeah,
kind
so
of have
we-
bridged that gap. Is there someone appointed from the department that actually does that? Or is that you or?
There's our team of 3 that works on distributing that information. We work with our communications team with DCFS, and then of course Assistant Secretary Hanneman and Secretary Harris help us to distribute that information. But much of it is done through the contacts that we've established, during the time in our role.
Okay, so now I don't know if I want to get so technical, but I do want to know what the money that we actually budgeted for this, because we were given how much it would cost to actually implement this. It doesn't sound like anybody new was hired to actually kind of take this on, because you're already there. Who else was added?
To implement, which part of it? I'm sorry.
Well, there was a lot that was asked for in the
So-
budget. So has that person been provided or added, or have y'all hired them yet?
As far as the communication that went out to the health providers, that's what our team took care of.
Mm-hmm.
As far as additional staff, we have hired 51 additional staff members to start
Okay.
a second shift for DCFS.
Okay.
That will not be only limited to alternative response. They'll be able to investigate like any type of investigation that comes in, but we have increased our staff across the state. And our caseworkers are also directly communicating with our healthcare providers. But if there's anything that needs to come out from an agency standpoint that is healthcare related and needs to like globally go out, then that is our team's responsibility to make sure that we are getting it distributed across the state and trying to utilize any partners that we have to get the word out.
Okay, and I would, yeah, and you turn your light on so we can have you to chime in, and we can have this conversation a little bit further, because I'm going to go back and look at the budget. I'm not looking at that now to see, because I want to make sure that as we put this into place and put it into law, that it is actually being fully implemented, especially since we allocated the funding for it. Yeah, let me see, do all of us add? Mr. Hanneman?
One of the things that doctor spoke about was when the calls come in, and the majority of those calls usually coming in after school and into the nighttime. So we hired those 51 people, 153, we have 51, now we're bringing 2 more on, because when that second shift rolls out, that will go from 1:30 until midnight,
Okay.
covering weeknights, weekends, and holidays. So what we did is we looked at our data, spoke with some of the hospitals, saw where the greatest need was.
Okay.
So we took that funding, applied it to these new hires so we could close those gaps.
Okay, okay.
And we still have coverage after that night shift. It'll be an on-call basis. And so we have 24-hour a day, 7-day a week, holidays, nights, weekends coverage. So
Okay.
that has not changed either.
Okay. So I want to go back through your numbers right quick before I go to, I think Ms. Shelton may have a question. So you said 43 alternative responses, 41 child-on-child, and only 2 were deemed to be investigated?
No, two
No,
in
no.
school settings.
These were 43
okay.
that were investigated. 2 were in a school setting.
Okay.
Yep.
Okay. And how many did you guys actually decide to, you investigate?
These are all investigated. These
All
43 were
okay.
investigated.
So the 2 were at schools?
Yes, and the others were children that lived together in the same residence.
Oh, okay. So the 2 that were at schools, what age?
Out
of curiosity.
I don't know if I have the age breakdown.
I don't have
I
that.
don't think I have
Okay.
that, but we can get it for
Okay.
you.
All right, great. Thank you. Ms. Shelton?
Just clarifying, investigated or alternative response?
Thank you for clarifying that. It was an alternative response.
Okay, and you said 2 rose to the level of investigation.
No,
Is that what I understood?
No, there were 43 alternative responses. Now,
Okay.
we may have had additional cases that rose to the level of investigation, but these were the ones that we responded to as an alternative response, and so that's the data that I have.
Okay, and then my follow-up question to that was the second shift. Are they trained to be CIs and do the alternative response, or do you have a special alternative response section? How is that working?
No, they're going to be fully trained, and they'll be able to handle both.
Investigations
Yes.
and alternative
Yeah,
response?
they need to be.
And well, what about
So
your
we
current
redid the training on
investigator?
that also.
Okay, so the current investigators are trained to do alternative response and the new hires,
Absolutely.
and investigate?
Yes.
Okay.
And the new hires are currently going through training too, so they
Correct.
have not started picking up cases yet. Like, they are currently in the training process, but they have been hired and they are being onboarded.
Okay. Do you have any data, and you might not yet, if, I know part of the alternative response, looking through the policy, is they do evaluate if it needs to be turned over to investigations, parent culpability. Do you know if any of those cases have been turned over to investigation?
I do not have that directly in front of me, but we may be able to get it to you all before the end of even the task force.
Okay,
Okay,
thank you.
that's all? Okay. Okay. Mr. Pettit? Pettit, yes. Okay, he should be on.
Good morning, Captain Joe Patu with State Police. Thank you guys for being here, and thanks for the work that y'all do. I know it's very, very difficult work. I wanted to ask a little bit about feedback that each of you had in terms of law enforcement. You mentioned that the resources run the gambit, and that's certainly true. And I know you may only be able to comment in your specific areas, but best that you can. If there are any gaps that you're seeing in response or investigations, with those resources in mind, if you wouldn't mind sharing, please.
I feel like from my perspective, we have a positive relationship with law enforcement. Once the special victims officer is sent out to the hospital, I do feel like we collaborate well, and they are available, all times of the weekend and night and everything. Yeah.
I'm fortunate enough to be in a setting where there's generally a detective assigned, and so we're really able to build that collaborative relationship through repeated cases with them or multidisciplinary team meetings. And so, again, I feel like we have a good relationship with actual detectives and their sergeants and things of that nature. I would defer to the expertise of the emergency department physician with regard to patrol officer response.
Thank you.
I think we have a good working relationship with most of EBR. Like, it's unfortunate, but we start to recognize faces and names after a while, and so the cadence being so regular kind of affords a little bit of a working relationship. And so I think, again, like I said earlier, the understanding that these are kind of like very high critical value cases and everybody's very emotionally, physically invested, affords a level of just collegiality that happens. And I think it's been a good working relationship. And obviously, if anybody from PD has any feedback for us, we'd love to hear about it as well.
Thank you.
But most of you guys are in metropolitan areas, right? So New Orleans, Baton Rouge. Baton Rouge, yeah. I just wonder if that's the same across the board when you start going to some of the more rural areas.
I mean, we call in police from, the area where the alleged event happened. And so I met a police officer from Point Capee yesterday. I think in general for these response times, when we're talking about the safety of a child, it kind of heightens awareness of like who needs to come in and those kind of things. And I think the understanding of how grave the ask is there. And so I think we have a good understanding of like the pieces that need to happen and what needs to happen next.
Okay, great. Representative Edmiston.
Yes, thank you, Madam Chair. I just have a question. I apologize. I probably should know this, but what is alternative response? Can somebody define that for me?
I'm going to let Dr. Hook do that. Dr. Hook?
So just to put it kind of in general terms, we're able to go in and assess a family. So for example, if there was a child that was assaulted by another child in a school setting, the agency would then go in and approach both that family of the child assaulted and the family of the child that was the one that was engaged in the act that was committed against the other child. We would talk with that family, assess that family, make sure that there are no red flags or issues within that home. And then if we identified any potential abuse or neglect in that home that would raise to the level of an investigation, then we would change that investigation. We would make it an investigation, not an alternative response. However, if what we're finding is really that there is some, maladaptive sexual behavior in one of these children and they really need resources, then that would be the role of the agency, is to provide like resources, referrals, make sure that they are engaging with some services outside of the agency, but just making sure that we've assessed, the home unit to make sure that there's not, maybe abuse going on in another setting.
So in that case, would that still be an alternative response, or would you open up an investigation to make sure that the resources are provided?
We would only open up an investigation if we identified something that would raise to the level of what is currently in law.
Okay.
That would be warranted as an investigation.
Mm-hmm.
We can offer family services if we were in a home and there was some type of family service support that was needed, then that also is something that we can do. But it would not be necessarily that family was being investigated for abuse or neglect.
Okay. Would you say that the percentage of your referrals go to alternative response or investigations?
Oh, the majority of our calls our generalized intake are investigations.
Okay.
Alternative response, we had that several years ago before I was with the agency, and then we stopped using alternative response.
I had never heard of that before.
Yeah,
Okay.
and we haven't used that until Act 409. So that just started, and I've only had 43 cases right now of alternative response. We had, I think it was 22,000 investigations in fiscal year 25. So it's a very small portion currently.
Of the alternative.
Of all of our calls.
Right.
Yeah, alternative response is a very
It's
small
very
portion
small,
at this
yeah.
point.
Yeah, I just wouldn't want, something that really needs to be investigated to get
No.
shoved off into alternative
No,
response.
this actually was a way with Act 409 for us to be able to make sure that the children that needed services were getting them.
Okay.
So these are cases that actually, had they been called in previously, they would not have had any response from the agency because they would not have met the criteria for investigation.
Okay.
So we may have referred to law enforcement depending on the circumstances around the case, or it could be that both families were then left to try to identify services for themselves or
Okay.
to make sure
Yeah.
that they were safe.
Okay.
Now, one of the things is that there are times that we might refer a family for services and those services might not be available, or there might be a long wait list. And so those are real issues that we are
Give me a
working
for
through.
instance on that.
For example, if we identified that a child needed, behavioral health care, there's a lack of providers across the state, and especially if they needed a specialized type of behavioral health care, or we thought that was something that they needed, we might say, hey, it's very important for this family to get counseling. These are some counselors we've used in the past. We want you to get in with your physician, but we can't really control the time frame for those
understand
services
that,
to
yeah.
occur. And many of the services that children that are the victims of sexual abuse really need, there is a scarcity of amongst the communities in the state. And so I think that's another issue that we really need to, talk about and try to figure out how to address
Yeah.
those needs.
And I'm thinking in the case of the alternative, there's no caseworker that follows, in other words, whenever you figure it's not something that needs to go any further, then they're kind of left on their own. Is that correct or not?
Once that response has ended, there can be like a referral to family services. There could be, an investigation. But once the agency has closed whatever their involvement is, then
Okay.
yes, the family would be back, working with their community and their providers
Okay.
outside of DCFS.
I wish we had somebody to track those families.
Yeah.
Thank you. Appreciate it. Thank you, Madam Chair.
Thank you, Representative Evanston. You bring up a good point. Ms. Shelton?
Just had one more question. I believe it was Dr. Mehta, I think, maybe not, who has the subspecialty program. Can you explain to us what that is so everyone on the task force knows? And is that what region it covers? And is it something if it's anywhere else in the state?
So child abuse pediatrics is a relatively new subspecialty, just like you can have a pediatric cardiologist or a pediatric gastroenterologist. In 2009, the American Board of Pediatrics started allowing physicians who had specialty training in child abuse medicine to be able to sit for this board examination. And then since then, it is required for anybody who's in this field to complete an accredited child abuse fellowship. So after becoming a pediatrician, physicians then take additional training in a specialty program where they learn exclusively about child abuse. I think all fellowship programs are now 3 years. And then after that, they can take this certifying exam. In our state right now, I believe we have 5 people with, or pediatricians with specialized child abuse training. 3 of them are at the program at Manning Family Children's. One is semi-retired, and she, I believe, works in Jefferson Parish, and then one is in Shreveport. And so it is a fairly limited resource. We are about average compared to the United States in terms of numbers of people per population, but it is concentrated therefore on the southeast part of the state and then that northwest part of the state, and not something that's as available further out. We pretty much will see any kid who can get to us. So we have had kids who came all the way from Lafayette, but that's really usually the extreme case of like a severe child abuse where those investigators make sure that that child gets to us. For the most part, we're serving the parishes surrounding us. So it's, Plaquemine, St. Bernard, Terrebonne, Lafourche, Ascension, Livingston, Tangi, St. Tammany, Washington, just sort of that geographic area is primarily where we're seeing patients. We do have a satellite clinic that we provide in Covington, and that's been of assistance to people on the North Shore and in Washington Parish. And then we have a satellite clinic here in Baton Rouge. And so after they've had that acute examination in the emergency department, or if they've had evidence collection, after they go to that child advocacy center program, they're then referred for that sort of more detailed evaluation by one of the providers from Manning Family. But that's not, you were correct, it is very geographic.
And is the referral, if I understood it correctly, just from a CAC, or can a parent come and ask that?
a parent can come and ask. And so there's no out-of-pocket cost to families. It's a community benefits program of the hospital, sort of in their drive to provide service to the community at large. And so it should be no barrier to access.
Thank you.
Thank you so very much for that question. I do want to thank each of you so very much for what you do, the work that you're providing in our community, to our state. From your perspective, though, is there anything that you have seen that you wish we could do differently, or that you would recommend or suggest that we may want to take a look at in terms of maybe law or maybe procedurally that can be implemented or should be implemented or considered to make it a little bit easier? I have to tell you, I don't know if I have moved beyond the 105 hours or 73, the 3-day time frame. I'm still stuck there because I know that creates a huge barrier.
And the time frame is really set by the likelihood of collecting evidence. So it's not to exclude children, it's more to capture as many kids as we think there's a chance of getting evidence for.
Mm-hmm.
I think the difficulty is so many prevention programs are focused on telling children that if something happens to them, they need to do something about it. And the more evidence-based practices or programs like Darkness to Light that really put the responsibility on the adults and say that it's really up to adults to make sure that children are not being sexually abused, and we're not relying on children to identify that they are victims. And I think that mind frame, so many parents prepare their children for stranger danger, as opposed to maybe the reality that it's not somebody who's beating them up or abducting them, which can happen.
Mm-hmm.
Those are important things to prevent or to warn your child about, but that is not the majority of child sexual abuse.
So maybe we should be doing more on that end with parenting as it relates to things that they should be sharing or telling their children, or things that they may be engaging with them on, and so that they can see or be able to witness a little more, I guess, quicker. If they see something strange or something that doesn't look right, or maybe just asking a line of questions to their child. Is that something that y'all are saying maybe we should be doing or encouraging more of? I think, is that what I heard you say, Dr. Mehta?
Sort of. It's kind of a complicated question because individual parents are going to approach things differently.
Yes.
And so I can't expect every parent to question a child the way maybe a social worker would.
Yeah.
And so parents I'm a parent, and I would treat my own child differently in a conflict than I might a patient. So, for example, if it's my child and I'm worried about something, my tone might change. I might sound accusatory. I might be interrogating. And so my child may not perceive this as an open environment for discussion. They may perceive this as, Mom's going to be really upset if I answer this question differently than what she expects to hear. I think that's part of what makes it difficult. I think having that open relationship where children can come to you, but encouraging parents to quiz their children can be problematic in that it might feel like the kid's scared of what they're being asked and what the consequences might be. Developing an open relationship where the child's not afraid, like if I go to my parent and I tell them something, they don't get really angry at me, would potentially be very, very helpful.
And I understand exactly what you're saying, because I probably would be the same way. Not angry at my child, but just angry at the fact of thinking about. So, what's the name of the program? Darkness to Lightness?
Darkness to Light is, I have no specific connection to the program. I'm just familiar with it. I just recognize it as an educational prevention program that is used generally in communities. It's something that you could provide as a training to employees at a Walmart. It's something you provide to teachers at a school, daycare providers. And the idea is to help people understand that putting the burden of child sexual abuse prevention on a child is not fair. So an example would be if I'm a parent and I'm going to pick up my child from soccer practice, and there's a coach there, and there's my child, and there's one other child. I could just pick up my child and leave. But I also recognize that there's an adult with a child, and I'm leaving them alone together, and maybe that's not the best idea. Maybe we shouldn't create situations where we are intentionally leaving children in vulnerable areas, maybe I stay until that next parent comes, helping people identify things that we can do as an adult.
That's good.
You know, having maybe situations, for example, where we sort of think, oh, well, you know, somebody's alone in that room with that person, we're not allowed to walk in there. We shouldn't have those situations. Those should have open glass cutouts in the doors so anybody could walk by and see what's happening. Or we should make sure that there's another person with us if we're going to be in a strange situation, like, you know, if a patient says that I need help wiping. Well, I don't want to be alone in the bathroom with a patient who needs help wiping. That's a vulnerability for them and a vulnerability for me. It's recognition of situations like that. That is
think that's
my
really good.
my bullet points about it, but I'm not even an authorized trainer of the program, so I'm just sharing what I know secondhand.
Well, I really appreciate that perspective, and I like the fact that we're taking the onerous off the child and really putting it more on the adults, and I think that's something we need to have more of a different conversation about.
When you talk to the child advocacy centers, many of them have community prevention programs, and there are there is some grant funding for people to provide this type of training. So many of them are going to be able to tell you about what they've been able to achieve in their communities with this type of programming.
Okay, good. All right. I do not see any additional questions for you ladies. Again, thank you so very much. We thank you for taking out time to be with us today to share this very valuable information. And we certainly are taking it all to heart and seeing what changes we can actually implement and continue to keep the ball moving forward.
Thank you for addressing this topic. We really appreciate it.
Yep, thank you. And I need you to fill out a card. Okay, thank you. We have Dr. Poche, and I'm going to ask Dr. Cavanaugh to come to the table together. LCMC? Okay, all right, great. Thank you. Okay, Dr. Cavanaugh, thank you so very much. We are glad to have you here. Would you please introduce yourself?
I'm Dr. Cavanaugh, and I am a medical doctor. So I work in an outpatient psychiatry clinic. I trained in pediatrics, adult psychiatry, and child psychiatry because I have a special interest in treating people with developmental disabilities like autism throughout their lives. Although I do see adults and kids and all types of psychiatry. So I'm here today to talk about a case involving the many disciplines that are involved in keeping children safe in Louisiana. And I think I can provide a lot of answers to some of the questions you asked earlier, just from my perspective as an outpatient doctor. I'm going to take particular note of the mistakes I have made along the way in hopes that this will open the doors to change for the better. And toward the end, I'll make some specific suggestions on things that could be changed to help keep our children and patients safe. So I have 7 suggestions. There are many more, but these are the 7 I chose to talk about today. Some are related to child sexual abuse, and some are just related to child abuse in general. But brace yourselves because this is a difficult story to hear, and please write down your questions to ask me at the end. I've changed all the names to protect privacy, so let's call the child Timmy and the perpetrator Mr. H. I first saw Timmy August 2023. He was referred by his pediatrician for management of his ADHD, autism, and Williams syndrome. Williams syndrome is a rare genetic condition where children are born with a low IQ but are very verbal. Because they can speak in full sentences, they often seem more intelligent than they are and are known to have a cocktail party personality. So they can talk, but sometimes not really say much. And they're always smiling, no matter how difficult the subject matter is. So it can be a little bit confusing if you don't understand the syndrome because they're always smiling and look happy. So Timmy loved basketball and the movies Home Alone and Fast and the Furious. Timmy was attending 8th grade at a public school in a special education classroom with a one-to-one paraprofessional. In November 2023, Timmy started having violent episodes and abrupt change in his behavior. In December, his mother called and stated Timmy wouldn't get on the bus to go home from school, and a teacher found him walking down the street, and he does not know how to cross the street safely. In March 6th, 2024, mother reported Timmy had a meltdown at the grocery store with his class. March 21st, 2024, mother reported Timmy was smearing feces at school and home, a behavior he had never done in the past. And mother stated, none of the medications we have tried were helping. She was having a very hard time getting him to go to school, and he used to love school and go eagerly every day. The aggression was noted to be mostly in the afternoons after school. By this time, Timmy was in FINS for truancy because he missed so many days. That's families in need of services, if you're not familiar. So if somebody is truancy, the family would be referred to FINS. I recommended mother notify the school board about safety concerns in the classroom after Timmy reported some child-on-child sexual abuse that he felt that the teachers ignored. He said that they laughed and didn't help. But the next day, mother called me with Timmy there on the phone and stated that after she reassured Timmy that no matter what was happening in school, that he was not in trouble, he finally told her what was happening. Timmy reported to me that his paraprofessional, Mr. H, had touched his penis more than once, and it first happened in 7th grade. I directed mother to call the Child Advocacy Center in their parish, and I made a DCFS report. So that was on March 21st. On April 1st, 2024, mother called and stated Timmy is now talking about the abuse by Mr. H, and something new is coming out every day. Timmy told her that Mr. H showed his penis to Timmy and 2 other boys in the bathroom at the grocery store. Mother stated those 2 boys can't talk, and she thinks one has Down syndrome. Timmy told me the names of the boys, and that in the grocery store bathroom, he was touching all of us together. Mother explained that the special education class goes to the grocery store once a week to stock shelves. Timmy told me that Mr. H told him to keep a secret and don't tell it to nobody about the gun and the wallet and all that. Timmy stated Mr. H had a gun at school, and I'm scared that he's going to hurt Mama. I told Mom that if it becomes too much to bear, tell him, thank you for telling me. You are so brave. Let's make sure to talk to Dr. Kavanaugh about this. I made a second DCFS report with the new information above. I got a letter back from DCFS dated April 2nd, 2024 that said this letter will be sent to law enforcement for their consideration. I do have copies of that letter that has been redacted if anybody wants to see what it looked like at that time, although it sounds like it may have changed since the passing of the recent bill. On April 7th, 2024, Timmy was seen in the emergency room for suicidal and homicidal thoughts. Timmy told family he would throw himself through a window or would get access to a firearm and use that to hurt himself and Mr. H. Timmy's godmother reported that she carries a weapon on her person and that Timmy tried to grab the weapon from her purse. According to emergency room records, Timmy was able to discuss different feelings he has. Timmy reported to the ER doctor that Mr. H took him into the bathroom at the grocery store and touched his private parts. On April 8th, 2024, I spoke to his mother, who said Timmy had to be restrained in the ER because he was so upset and they couldn't find a psychiatric bed, and after 24 hours, they recommended she take him home. Mother stated Timmy had been pacing since he got out, pacing and talking about random stuff, not the normal Timmy at all. Mother stated he was up until 3 a.m. checking locks and windows. Timmy says Mr. H followed the school bus on a white SUV Ram, and believes Mr. H knows where he lives and is scared Mr. H will come there. April 11th, 2024. Mother brought Timmy to see his longtime pediatrician to follow up on the anal tearing that was found on his forensic exam at the Child Advocacy Center. The pediatrician saw an anal tear in the process of healing. On April 15th, I saw him in the office. A mother said, Timmy is going to sleep with medication, but still wakes up twice to check the door. Timmy told me he had a dream. Mr. H stick his finger in my butt and all the poop came out. Timmy stated it happened in real life, a lot of times. I asked if it was helpful to tell the police, and Timmy stated, I don't know, more scared. Timmy stated he worries the police will hurt him. Timmy became more agitated and pacing and agreed this stuff is hard to talk about. According to Timmy's account, he told his mother that Mr. H works for juvenile jail and that if he ever told, he would take Timmy to juvenile and kill his family. Mother stated she is nervous to send his brother to school and is going to do homebound for both of them. Mother stated she feels guilty having made him go to school when he was being harmed there. In May, June, and August, I communicated with the family about Timmy's aggressive behavior, and family was never contacted by DCFS, and no one from school or law enforcement had notified them if Mr. H was arrested or still working at the school. Mother wanted me to write homebound paperwork, but I know Timmy used to love school and wanted him to get back there. So I start calling people. On August 20th, 2024, police stated, so this is 5 months after Timmy initially disclosed. Police stated no arrest was made. I called DCFS and discussed my concern for the safety of the children at the school. The DCFS worker stated they do not investigate abuse made at school, only abuse at home or by caregivers that are not teachers. So that is probably why it was sent to police. I asked what I should do now to protect the other children at the school. DCFS stated I should assume that the school knows nothing and make sure they are aware of what the child reported to me. So I called the school. I called the school principal, who was horrified to find out that the teacher was not arrested. He stated the teacher was fired and was hoping Timmy would come back to school. I said Timmy won't go back to school if he thinks the man still works there. So I called the DA's office to see what happened, and the district attorney explained that when a victim makes an allegation, and I'll have to say this slowly because it was, by this time my brain is circling. I'm like, who is telling people what and what's happening here? Okay, so the DA explained that when a victim makes an allegation of child sexual assault, then law enforcement investigates, and in that parish, it's presented to a multidisciplinary meeting with DCFS, the Child Advocacy Center, the district attorney, and law enforcement. Then the law enforcement agency decides if an arrest can be made. The district attorney explained, so this is like the head DA of the parish, but then there's like other DAs underneath them. So the head DA explained that since no arrest was made, she was not made aware of the case. I expressed concern that the family was not notified that no arrest was made and that no one got collateral information from me or the pediatrician, so the investigation did not seem thorough. The DA recommended I speak to the lieutenant. The lieutenant stated he is sorry they dropped the ball. Someone was supposed to tell the family that no arrest was made. I asked how it was a thorough investigation when no one called me from DCFS or law enforcement and no one requested my records. The lieutenant explained that he didn't even know I reported, that DCFS doesn't tell the police who reported. He stated that I can make a report to the police, but not right now with him. I would have to call back. Then I start wondering if I did something that contributed to my patient having to tell his traumatic story over and over again and not getting the safety and reassurance he needed to leave his home. Sorry, 1 second. This is a family I know really, really well, and I saw them yesterday, so it's hard to talk about, even for me.
Take your time.
I always sign up for a confirmation letter from DCFS, which is Department of Child and Family Services, to make sure that they got my report. So I fill out a report either online or on the phone, and then they immediately send me an email that says, we have received your report, which I love. And then a couple of weeks later, I will get a physical hard copy piece of mail that has like a number of check boxes. And you have to, it's, the only thing identifying the patient is their initial. So you have to like remember how many, who you referred. I looked back, I actually refer 1 to 2 patients a year to DCFS, and I am a child psychiatrist. So like most doctors probably maybe send like 1 a year or less, okay? So the whole process can become fuzzy if you don't do it all the time. So I got this letter back, I recognized the initials, and the box was checked that said, the information provided does not meet criteria for which DCFS is authorized by law to investigate. However, this information will be sent to law enforcement for their consideration. If you have not already done so, we urge you to notify law enforcement of your concerns about the family. That clearly says that DCFS is not investigating. I just, whoop. I just really focused on this information. So I misunderstood that this information to mean my name. I thought DCFS would tell law enforcement that I reported so that they could call me for collateral, but DCFS told them everything about my name. DCFS informed me that they cannot tell anyone, not even law enforcement, who made the report. Now, one might assume that law enforcement would ask the family who made this report or if the child had seen any doctors about this, but in this case, they did not. The child was seen at a child advocacy center, which is the gold standard of child abuse investigation. Child advocacy centers are intended to have multidisciplinary teams, meaning there are people from many different disciplines like law enforcement, DCFS, medical doctors, maybe nurses, social workers, on the team that makes a decision about how to proceed with the case. I have come to learn that some parishes have teams that are truly multidisciplinary, and other parishes have child advocacy center teams that include several different types of people in law enforcement, which is one discipline and not multiple. Unfortunately, this child was molested in a parish with a child advocacy center team that consisted of 3 law enforcement officers. Law enforcement did not obtain records from this child's pediatrician that show he had anal tearing. This was the same finding obtained by the Child Advocacy Center doctor, but that doctor is not on the deciding team. Law enforcement did not call the pediatrician to speak to the provider who had known this family since Timmy was an infant, who described this mother as a low-drama mother and stated nothing like this had ever happened with this family before. This mother is not litigious, and having this disabled child at home with her all day would only cause her problems. When I talked to law enforcement about why no arrest was made, they said there was no case because Timmy could not tell 2 different people the same story. They thought Mom had planted this in Timmy's head. I know from the medical record that Timmy had told the exact same story to the principal, me, his pediatrician, and the ER doctor. I asked to hear the taped interview at the Child Advocacy Center, and the officer stated I was not allowed to do that. I hear this often from law enforcement, though, and DCFS workers, this idea that a child made something up or a parent put it in their head. But this is a very dangerous assumption to make in any case. Children have no reason to fabricate being molested. It does not benefit them in any way. Timmy could not explain to me if Mr. H was in front of him or in back of him, but he could show me with puppets. So I'm going to show you one way that I have individuals with developmental disabilities communicate with me when they don't have the language skills to explain what happened. So I also have a drawing. I don't know if you want me to pass these around. This has also been redacted. But so for this patient who speaks a lot, but mostly about Fast and the Furious and Home Alone, he doesn't really understand right or left or front or back. But when I handed him puppets, these two exact puppets, and I said, okay, this is Timmy, this is Mr. H. What happened in the grocery store bathroom? And he went like this, and like this, and like this, and he drew a picture of a sink, and then he went like this. So to me, that is just as valuable as him verbally telling me what happened. He also drew a picture for me. And he said that this is Mr. H, this is Timmy. Mr. H was touching his penis, and I asked him, could you write that down? And he wrote Penis. And then he said, I think he was trying to kill me. And then I said, do you think you could write that down? And then he wrote that down for me. This was in April of 2025, so over a year after he initially disclosed. Timmy's family has moved twice to help him be less scared so he can leave the house. He has not been to school since March 2024. Arranging homebound has been a stress on an already stressed school system. If you don't know what that is, that's where a teacher actually goes to the child's home. So one teacher who could be teaching 25 kids is now teaching one. So it is, it's a humongous use of resources. So where do we go from here? Well, I have some suggestions. Now, just remember, I'm an outpatient psychiatrist. These are just some thoughts that I've had that from my perspective, I think would be really helpful. But I'm not an attorney. I'm not a judge. I'm not in politics. I'm just an outpatient doctor. So my first suggestion is to make every child advocacy center in the state truly multidisciplinary. Ideally, 3 disciplines or more making the decision to arrest or not arrest, but a minimum of 2 disciplines on the deciding team. My second suggestion is have fewer but more highly trained DCFS workers that can quickly make decisions on when a situation is an emergency and how to proceed, maybe a master's level or higher. And I say that partly because, when I was in medical school and I was deciding what kind of doctor I wanted to be, I never thought I'd be a psychiatrist. But then when I was looking into it, I was like, 5 years to be a psychiatrist? That sounds ridiculous. You just hear people's stories and you have some pills. That's not that hard. But it actually is really, really difficult to hear stories like this many times a day and then go home and be a wife and a mother and a sister and a friend. It's hard. It takes years and training and people teaching you that you can only control so much, that you have to take care of yourself to take care of other people over and over again. So for somebody who has had very little, and I don't want to say experience because you can be working for 20 years and not have the best training, so I think training is really important. But the turnover at DCFS right now is so high that I've had patients and parents wait months to get in to see me to ask if they can see their child again unsupervised, when I have nothing to do with that. I don't even know them, and so then I call DCFS and find out that their caseworker no longer works at DCFS and there's no new worker they have been assigned to, so they were lost in limbo. And I think one reason that it is hard to keep people working in a job that is this difficult, where they're not paid very much, is because the work is so hard. It is so, so hard. My third suggestion is to get the Americans with Disabilities Act to apply to law enforcement in a meaningful way when interviewing somebody with special needs. I recommend, so these are just some suggestions that might include, some specific suggestions.
Will you start that sentence all over again? Number 3.
To get the Americans with Disabilities Act to apply to law enforcement in a meaningful way when interviewing special needs child abuse victims. So these are some examples of what that might mean on the ground. I recommend that children with special needs have the person who understands their language best, that they are most comfortable with in the room to support the forensic interview. For example, with Timmy, I talked to him alone several times over the past year, and then I realized that really we had to have his godmother or his mom in the room, or he was really scared because he didn't know who to trust. You know, he had told many adults, and nobody made it safe for him to go back to school. So he really didn't open up until I allowed somebody else to be there. Even though I would say, like, maybe don't say anything, but just could you just sit here? He was much more comfortable. Also, I have a lot of children that they can make a lot of sounds, but I can't understand them until I've known them a long time. So sometimes having a caregiver in there can really translate. They can be the translator for this child in these special cases. This may mean seeing the child and caregiver multiple times in order for law enforcement to understand the child's language and abilities. Like I said with Timmy, he smiles, he can say lots of words, so I think unless you Googled Williams syndrome and understood the cocktail party personality thing, I'm sure law enforcement was like, well, this is bizarre, Another suggestion to help Americans with Disabilities, I think having a caregiver in there to help understand their language and seeing them multiple times will be beneficial to children and to the accused, because what we were searching for is the truth. And I think a lot of times in these cases, there are misunderstandings both ways, accusing people of things that didn't happen just because somebody misunderstood the story. My suggestion is that the default should be to believe the child. The default should be to believe the primary caregiver that the child feels most safe with. I recommend to allow nonverbal forms of storytelling like puppets, drawings, sign language, or a child and caregiver demonstrating with their bodies what happened. People with intellectual disabilities may be able to say lots of words but can't tell the same story twice verbally. When they are scared, they may be silent. In those cases, it helps to say, was that a hard question? And if they nod or say yes, then try rephrasing it. So my fourth suggestion is that, so this is unrelated to Timmy, just child abuse in general. Collateral should be obtained before removing parental rights. Rights are important in this country. When a person is a danger to themselves or others, 2 doctors in this state have to agree to taking that patient's rights away temporarily. So in this state, it's called a physician's emergency certificate. So if somebody's in the emergency room, that doctor might sign a PEC, and then the coroner, which is typically a doctor, but I don't think always in every parish, they have to come within 72 hours and meet with the patient and decide, do they agree to take this patient's rights away, or are they going to rescind the PEC? I trained in New York, and there it was called a 2PC, a two physician certificate, so it was just 2 physicians right at that time. But the same idea, where it's not one person making this decision. In this state, if one parent accuses another parent of harming a child and DCFS says there was a bruise, an attorney talks to a judge, and the judge that has the ability to take that parent's rights away when they do not know the parents or the child involved. This is absurd and has harmed too many of my patients to count. I suggest that at least one person who is not a parent should be consulted before parental rights are terminated. Examples might be the child's teacher, doctor, or therapist. There must be checks and balances in order to protect children from all abuse, including the psychological trauma of being removed from a primary caregiver abruptly and never knowing if or when they might see their caregiver again. Okay, my fifth suggestion. Forensic psychiatry should not be the last people called in a custody battle. They should be involved from the very beginning. Forensic psychiatrists, if you don't know, they specialize where medicine meets the law. The vast majority of caregivers that split up work out the visitation arrangements between themselves and do not involve the court at all. If two adults are so unable to put a child's needs first that they need to have a judge make decisions for them, forensic psychiatry needs to be involved sooner, not later. Usually what happens now is the custody battle will go on for like 3 years, and then it's brought up, well, maybe you both should pay $800 each to talk to this specialist, and that person interviews everybody involved, the children, the parents, goes to both homes physically, does this really thorough investigation that we should have done at the beginning, after not dragging these kids 3 years to this battle. My sixth recommendation is that DCFS and law enforcement speak to the pediatrician and other healthcare providers to get a better sense of the situation prior to making a determination on whether to investigate or arrest. And then my final recommendation is in reference to drug-exposed infants. So often, when a baby is born, the neonatologist or the pediatrician in the hospital caring for the baby is allowed to look at certain parts of mom's medical record. We could see their HIV status, if they have syphilis, hepatitis C, if they were group B strep positive before birth, things like that. But what I found out when I was in the NICU is that the prescription monitoring program, which is what our state uses to monitor when controlled substances are filled, like benzodiazepines, stimulants, opiates, that we were not allowed to look at mom's physician monitoring program record when the baby was in the NICU, which I thought was odd. Because this is very helpful information. It might show that mom has been filling her Suboxone prescriptions throughout pregnancy and that she is compliant with care and recommendations. It might show that mom has been doctor shopping and going from emergency room to emergency room, and that the stimulant prescription she has is from a doctor she does not know or has only met once. So it can be very helpful. Now, should that be allowed when the baby is still in the hospital? Should it be allowed the first year of life? Should people be allowed to look anytime there's a question of placement? I don't know. I don't know the answer to that. I'm a mom. I have 2 kids. Like, I want my privacy too. So, but I just think it's something to think about, particularly when we're in the middle of an opiate crisis, and there are lots of overdoses happening in front of children. I've actually coined the term opiate orphans for my patients that no longer have parents alive because of this epidemic. Now I can take questions.
Thank you very much, Dr. Cavanaugh. This was difficult to hear. I know that I have plenty of questions that I began to write down to try to follow what transpired. I don't see any additional questions right now, but first of all, what parish did this occur in?
Timmy's case?
Yes.
I intentionally left that vague because I wanted everyone to just imagine this could be any parish, because really every parish has their own issues. But this patient was in Jefferson Parish.
Okay. And I asked because I'm trying to see the correlation or the difference between rural and urban areas. I'm trying to just trying to understand. One of the things that you said is that Timmy did not feel safe. And so in order for him to speak, when he would speak with you, you brought in his, I think you say his mom or maybe the aunt?
Sometimes it was his mom, and sometimes it was his mom's aunt, who he calls godmother.
Okay. So did he report, did he share this information with anybody at the school and no one listened to him?
The principal was told and immediately called HR, law enforcement, and the teacher was fired from Jefferson Parish School.
Okay, so
he's, my understanding, when I was trying to get him back to school, is that the only place I could guarantee this person was at that school.
Okay. So he did tell the principal, and there was some action that actually took
Yes.
place. Okay. DCFS is where I guess it really kind of gets down to, because you talked about the letter that you received back on April 2nd, 2024. And then I have April 11th. I'm not sure what happened on April 11th, but is that when you got a response back, maybe?
On April 11th is when he went to see the pediatrician, because at the Child Advocacy Center, they found anal tearing, and then she was just worried about his gut and was like, do I need to go to a GI doctor? Like, what do I do with this information? So she brought him to the pediatrician, and the pediatrician saw healing anal tearing.
Okay, so that was the mom. Okay, and then a whole year later, April 25th, because DCFS was made aware, but because it actually happened at the school, then they actually turned it over to law enforcement.
Right. They turned over everything but my name. But they gave all the information except who reported.
Oh, okay.
Yeah.
Okay. Okay. And then law enforcement, and that gets really more frustrating. So I don't know if I quite follow what happened with law enforcement. So you reported, then the lieutenant told you to come back. Did you?
I actually never reported to law enforcement, and that is my fault because I have never been taught to do that. I have never met another doctor. I mean, I did 5 years of training at Tulane. I have been out on my own for 7 years. I have yet to meet another doctor who knew that if DCFS referred it to law enforcement, then the doctor has to report a second time, or law enforcement will never know you're the one that reported. It doesn't clearly state that in the letter, and I was never taught that. And now I ask doctors about this all the time, and I've yet to have one person that says, "Oh yeah, I knew that." Yeah, you have to always double report. And
we clarify that now in the law. So DCFS now, they're going to definitely know, and then they would make sure that law enforcement is certain, but they would definitely know.
Is that right? So
yeah, now.
Yeah.
Turn us all on, please.
I do want to speak a little bit. One of the things that you brought up, I think, is so important for the task force to understand. Medical providers we know we're mandatory reporters, but we are not by law required to take any certain or particular training. And so there are many healthcare providers that talk to me and say, I don't know who to report to. I don't know where this should go. I don't know what you investigate. And so I think that is probably something we should look at as a task force to see if there needs to be some type of mandatory reporter training that is mandated for healthcare professionals, because they do see a large portion of these types of cases. And it could be something that qualifies as continuing education for that provider, because we all have to do continuing education. But I think that would really help to solve some of these issues where maybe a dual report needed to be made, or perhaps a report should have been made to law enforcement. Because if it is a criminal act, then the report should be made to law enforcement. If you make that report to DCFS, then yes, we should refer that report to law enforcement. In the past, the way that happened varied across the state because there are some actually law enforcement agencies that they're not manned 24 hours a day. And so it makes it difficult. Right now, we are to call within 24 hours to refer anything to law enforcement that needs to be referred. However, we are facing some challenges with that. We've got workarounds. Once it's referred, we don't really have control over where it goes from there. But I do agree. Another thing you brought up was that multidisciplinary investigation. I think that's really important that as a task force, we look at that and make sure we're doing this the same across the state, because there's high variance of how these types of cases are being investigated and followed up across the state.
And I think just, kind of the medical team and law enforcement and DCFS working together more will be helpful because we have access to a lot of information. I can see I can see almost everything in the medical record and can see that this child is consistent in telling the story. But law enforcement doesn't know that, And so if they don't know to call me and get the information. So I thought also about talking about release of information and how HIPAA has contributed, but I understand DCFS is not bound by HIPAA.
It's a little tricky now because I'm still bound by HIPAA, but
Okay.
as an agency, we are bound to protect client identifying information. And so we can receive information from you and we should exchange that equally, especially in the course of an investigation. We do still supply you as a provider with a medical release. But yes, you are able to communicate with us when it involves not a medical investigation, a DCFS investigation.
And I think that that fact that it's okay to talk is not really known by everybody that is being sent out in the field to investigate. It's just I think that it's easier to say I can't talk to you until you sign a release than to have the training and expertise to know that in an emergency you can talk to somebody.
Yeah, you can. Now, some of the information that we can share back is limited because we have to also protect the people that we are investigating, so they have a right to some privacy as well. So sometimes it kind of feels like a one-way street of communication, and I've been on both sides of it. As a provider, I felt frustrated many times when I was giving a lot of information and not getting a whole lot back. But I strongly encourage, any healthcare professional, when it pertains to an investigation, to have those conversations with our DCFS investigators because it helps us to more timely, make a determination in some of these matters. And then also, when we talked about the default should be to believing the child, well, sometimes that's all we have to go on initially is that child's report. And so if we're not getting a lot of information back from the healthcare providers or from our community stakeholders, it's really difficult to complete that investigation. And waiting for records a lot of times can be a real hindrance because we will provide you with that medical release to get that full record. But sometimes if we have to go through your health information release,
That's
it can
why I
take
feel
weeks.
old school medicine, where you just pick up the phone and call, is so much better sometimes because these medical records are cumbersome.
Yeah.
And who has time to really comb through that?
We are not asking for anyone to provide any type of electronic record, outside of their organizations, practices or policies, but that verbal communication is protected by our investigation and can occur.
I have just so many questions, but I'm going to yield and see if anybody else asks some of the questions that I have because I think I could stay here all day.
Well, I wanted to
Hold up. Senator Hodges, and then I'm going to come to you.
Thank you, Madam Chairwoman. Dr. Kavanaugh, thank you for being here and sharing that horrible story. And it's difficult for us to hear, but it is necessary for us to hear to be able to see where the holes in the system are. I guess one thing that sticks out to me a lot does, as Madam Chairwoman said, but why wasn't the man arrested and charged with something?
The person I spoke with, the lieutenant, said that it was just determined by that non-multidisciplinary team. So 3 law enforcement people talked, and that they just felt like if this went to court, it wouldn't go anywhere, that this wouldn't, and that's a valid concern, right? Like, we don't want to send somebody to trial and have a child tell their story knowing that no arrest will be made, or, that's traumatic as well. But I feel like the investigation was not complete enough when they made that decision.
Contact you?
No.
Okay, so that's a problem, that they did not contact you as a psychiatrist to make an assessment on whether or not the case was sufficient enough for him to be arrested and charged with something. And the fact that he was, according to Timmy, perpetrating this on other boys, and now he's charged with nothing, no telling where he is and what he's doing. That really disturbs me. The whole thing is disturbing, but that is disturbing that it could possibly be ongoing.
Oh, for sure.
And I'm not sure what we need to do about that.
We need to find out, because that goes back to one of the other pieces of legislation that we passed as it relates to individuals who are dismissed from schools. And so I don't know exactly like what that looks like. So when he was dismissed, what was actually written up? Because did that go into his files? Or did it not go into his files? And is he actually working at another school where we know that we have teacher shortages, right? So individuals, he may come across as this person that is really, really good with kids, but we know that he is molesting children.
And especially disabled children who
Especially.
cannot communicate that.
Yeah.
I mean, that is unacceptable.
Right. And the one thing, and I think law enforcement will understand this, is like really smart pedophiles are very hard to catch, right? Like, this person, he understands that if you molest some, like right now in the current system, if you molest somebody who cannot speak and tell the same story twice, that is why he is in this role. That's why he chose, my patient doesn't need any assistance in the bathroom. He toilets completely independently. Why was he in the bathroom alone with 3 boys? Where were the other teachers? I don't know the answers to these questions, and they definitely keep me up at night. I think one thing for the task force to consider is to get somebody from education on the task force who might have a better understanding of the school board, or I don't know. I was not, when I talked to the principal, he was not able to give me much information other than that that perpetrator was no longer on the property, and that if Timmy wanted to go back to school, he could guarantee that person would not be on the immediate grounds. He can't guarantee he's not like across the street, but he can guarantee he is not an employee there.
That was this year that he was let go?
That was, it was within a week of the patient telling the principal. I know that mom was really upset. She wanted him marched off the property right that day, but I think there was an issue, law enforcement needed to be able to find him, So it was they had to wait for his next shift or something like that. So there was a little bit of a delay on having him removed from the premises, but yeah, all of that, there's no really transparency in that system. I don't know.
That's a problem.
I know. And I don't know if he was just fired from that school or if he can never work in that parish school system. I don't know
That's a
that.
problem.
We need to talk.
Then he can go into that, and they would not know that he was
Really?
working in that parish.
All of that is problematic, and we definitely are going to find out exactly what happened.
And this is the thing, is that I could call right now and report this to police, but I haven't done that because this is so traumatic for my patient, and I don't want to send him through the exact same rigmarole for the same outcome. Because if nothing has changed, why would the outcome change? If nothing has changed in the system.
So do we have someone from law enforcement here? Can you speak
Yeah,
to
so
this?
yeah,
issue?
right here. So look, so let me just say this, because we're not going to bring the family through any additional trauma, but we are going to find out if this individual is working with children. That is an absolute. We're not going to do anything on record or publicly, but we will find out if he is working in the school system with children.
Or juvenile justice, which is where he told my patient that he worked. But of course, that's where a pedophile would want to work. But
So wait, hold up. So he was working at a school, right? Mm-hmm. But he told the child he's working at juvenile justice.
And I don't know if that's true. I have no verification of that.
Maybe part-time.
But that's what
maybe so.
Yeah. And, it makes sense if you're working at a school and these positions are very hard to fill and you see somebody who's law enforcement, they have a clean background check and he wants to be a paraprofessional, you have to lift up heavy kids who are sometimes aggressive. Like, I could see why they were like, oh, great, this is a great hire. But like,
I can see that
hindsight is
too.
2020 and it's like, oh no, why would this officer want to work with disabled kids? Oh no. Yeah.
We will find out.
Yeah.
Okay, thank you.
Thank you.
Senator Hodges?
Well, thank you, Dr. Kavanaugh. I appreciate it. And could you speak to that issue of where the breakdown was here?
Hold on. Okay, he's on.
So first, thank you for the work that you do. I know it's very, very difficult to conduct these interviews, and like you said, to go home each night and to try and return to normal after a day like that. Senator, I can't speak to the breakdown here because I don't know exactly specifically what steps the law enforcement took. You make a lot of very good comments here, and one of the things that sticks with me that I kind of see is that law enforcement needs to be responsive, needs to be flexible, needs to be able to adapt to different conditions. And this is definitely an unusual or less usual circumstance for probably those juvenile or sex crimes detectives, and may have played a part in that. But as a profession, that's what we have to do. We have to be able to respond. We have to be able to be flexible, and that's something that's missing here. I like many of your recommendations, and I'll do my part to find out some more information.
Thank you. We appreciate it.
That I forgot to mention this, but so law enforcement did go investigate and meet with those other boys, the one with Down syndrome.
Okay.
So they investigated, but still they felt like there was no way to prove what happened. But do I think that they took puppets to their house and asked those kids to, I think there probably were other ways that they could have tried. But if they're not trained to do that, how would they know, So.
I personally feel, I know every parish does things a little, some parishes do differently, and we work with our district attorney partners, and we all have to work together in the same space. But, do I think every single case needs to be decided with an MDT prior to making an arrest? And the DA's office has to be involved each time? Maybe not. And that could be something that we could look at.
Well, I certainly do appreciate it, and I look forward to working with you as we work through this situation and then going forward. I do also really appreciate many of the recommendations that you suggested. Not only did you come and share with us this really difficult story that we needed to hear, that was hard to hear. And hard to believe that was actually transpiring, happening with one of our kids. But you came also with recommendations. And so that really makes it a lot easy. It makes it a little easier for us to try to figure out what we need to do next. Senator Hodges, do you have questions?
That was all. I really appreciate it, Madam
Okay.
Chairwoman. And I guess maybe state police needs to have some kind of protocol where they do consult with the psychiatrist. Not maybe, they definitely should. If there's a psychiatrist involved, especially when you're talking about disabled children who are nonverbal. I think that's your only way that you're going to get a conviction and get someone like this off the streets. So Thank you very much. Thank you. I appreciate it.
Thank you. Dr. Hook?
I just wanted to, because we are on this task force and it is public and people are watching this testimony, I want to just take this time to say that if a crime is committed, we have to report that to law enforcement. It is the law that we report to law enforcement as a physician, is what I'm saying. So, as community members, not as DCFS. Now, DCFS also needs to make those reports to law enforcement if we receive them, but just, keep in mind that DCFS, when we investigate a family, what we are able to do is to make a recommendation to the court system to say this child should be removed from a home. We are not able to bring charges against anyone. We're not able to do anything in the criminal realm other than sit on a multidisciplinary team and give our recommendations and advice. So it would not prevent somebody from going back into the community and perpetrating against others. So just want to make that really clear that we do have a duty to report any type of criminal acts to someone that can do something about those criminal acts in a way of an arrest or, some type of further, follow-up. And then we also have that same responsibility as an agency. And so if there was a breakdown from our agency at any point, then we definitely need to explore that because this is obviously a terrible case that we're talking about. So just know that we all own a little bit of this, even when we leave the room. When we're in our own lives, we have to think about how we have to report because we can't assume that the report was received.
Ms. Hadley?
Yes, I just wanted to just piggyback off what Dr. Hook was originally saying about making referrals out. I think with these cases, we also need to understand the time sensitivity when it comes to children like that. So also, as a task force, I feel like it's important to also look at the time frame of if only DCFS is reported and then they refer to law enforcement, what's the time gap in that as well? How can we make that more efficient and streamlined to be more of a quick response with our younger children and then children with special needs as well?
Well, I have to say that I think the timeline was really, I don't think it could have been faster. So the breakdown was that law enforcement made a decision and never notified the family. So mom is, going to the ER. She told the ER doctor, it's already been reported to DCFS. Don't worry. People are working on it. But we didn't realize, she didn't realize, I didn't realize the pediatrician, we all just thought it was like being investigated, and it wasn't. It was closed. No arrest was made. So it was like maybe within 48 hours of him reporting, so we did the CAC meeting. Sometimes the multidisciplinary meeting is, a week or two later, but I think the whole thing was wrapped up in 2 weeks, and we just were never notified.
Hold up.
Family was never notified. I was the one who told the family.
I don't either. Ms. Hadley?
I know you mentioned they said that the child received a forensic interview as well, and that was within 48 hours.
So my understanding, and you should probably get somebody in from the CAC in Jefferson Parish.
CAC. She is the CAC.
Oh.
Not Jefferson, though.
Oh.
Yeah, she's Jefferson.
I am Jefferson. Oh. Yeah. So, wait, tell me your question one more time.
I was just understanding if it was such a quick turnaround. I was wondering, sure,
so
was the
my
forensic interview
understanding
within
is that the
48 hours as
CAC in
well?
Jefferson Parish, and correct me if I'm wrong, is 3 law enforcement officers, and there's maybe like a social worker, but that person doesn't have a say in if the case's investigator goes forward.
Yes, you may.
Hi.
Good afternoon, everyone. My name is Erica Dupape. I am the Executive Director of the Jefferson Children's Advocacy Center. I've been the director for about 15 years now, but I started out as the forensic interviewer 20 years ago. The Jefferson Children's Advocacy Center is a nationally accredited children's advocacy center, and so by that, we are required to have a fully intact multidisciplinary team, which includes representatives from law enforcement, child protection, the district attorney's office, our mental health professionals, our medical professionals, as well as our victim advocates and community ad hoc members. Specifically, when it comes to law enforcement, we work with JPSO, Harahan, Kenner, Westwego, and Gretna Police Departments. We have MOUs with the FBI, we work with the military bases, and I can assure you that every MDT we have has representatives from each of those entities present at the time of the MDT. We routinely case review any child's case that is brought to our center. We see that every case is staffed within 2 to 3 weeks, depending on whether or not a squad is on days or nights to be able to accommodate the multifaceted scheduling. I can tell you that while we are a multidisciplinary team, we do not always agree on outcomes. And as a children's advocacy center, we are a neutral facility in that we cannot make a determination if something has happened. All we can do is advocate for the rights of the child and ensure to the best of our ability that the team is actually communicating and working together. That does not always happen. Unfortunately, police don't like to be policed. And so law enforcement at times may make their own determination, regardless of whether or not a medical provider is providing actual physical information in their report. regardless of whether or not Child Protection is able to do anything, regardless of whether or not the District Attorney's Office is requesting a case be submitted to them. At the end of the day, we can only bring the entities together and do everything we can to ensure that the children receive the services that they need, because we know that so few of these cases actually see the inside of a courtroom. That is why we stress the importance of bringing children to the CAC to ensure that we're able to support the parents or appropriate caregivers to see that these children are receiving the services that they need, because so rarely do they actually see justice in the ways that they would expect. So while we are absolutely advocating for these cases, I can tell you, unfortunately, more than I'd like to acknowledge, how many instances in which our team may disagree with law enforcement. Law enforcement, at the end of the day, makes the determination.
Do you know if it's like that in every parish, that law enforcement is the final step in making?
When it comes to whether or not they may pursue charges, we oftentimes, if not always, encourage them to still submit it to the District Attorney's Office for a review, but not all law enforcement jurisdictions decide to do that. And so in some instances, they are the ones that make that final determination, regardless of whether or not the team may be in agreement.
That is troublesome.
Yes, ma'am. it
That's
is.
very troubling. And so we need to kind of dig a little further into that, because I don't know, and I don't want to put you on the hot seat, and I don't know if you can really respond to that, but that is very problematic for me on multiple levels,
Yes,
right?
ma'am.
I just reserved that comment. So do you remember? Does that case sound familiar? Do you remember that case?
I unfortunately can't confirm or deny, but
Okay.
I can say that we have had cases in which we do have nonverbal children and we interview them to the best of our abilities. One of the things that we are able to do is implement what is considered a multi-session forensic interview for cases such as what Dr. Kavanaugh is referencing. When we have a child that may be nonverbal or require additional time to become acclimated to the actual setting of the CAC, and also give our interviewer an opportunity to learn as much as they can on the front end on ways to best communicate with the child in question. So I can say that we have interviewed children where they may not be as verbal as another, but they are still able to give very credible information. But we do encounter instances where if there is not a consistency in statement, such as what Dr. Kavanaugh has referenced, we see that more than, again, we would like. I do go out into the community and I train our first responders on what's considered a minimal facts forensic interview, because we really do want to limit the number of times our children are being questioned. But unfortunately, even with the best of intentions, we have officers that decide they need to know everything beforehand. So by the time that the child gets to the detective or the child protection worker or to the CAC, the child is in an interview saying they don't want to talk anymore. And we can't fault them for that. And again, when I go to talk with law enforcement about this and really stress the importance of trauma-focused approaches, especially with these most sensitive of cases that are the most difficult to prove, I am often met with the child is not providing consistency in their statements.
So really quickly for you, and then for all the CACs that will be coming up in a few minutes, do you guys find, or do you find that in scenarios where the children have a disability, it's more dismissed when there are accusations, or when they have been, when they speak to say that they have some level of abuse?
I wouldn't say that particularly.
Okay.
It is a case-by-case basis. There are so many factors associated with the decisions that are made by the individualized case. But as Dr. Kavanaugh has mentioned, children with disabilities are at a much higher risk of re-victimization because of their ability to articulate whether or not something has happened. And unfortunately, what victims have to go through after they've disclosed can oftentimes be more traumatizing to them than the abuse itself, because they are the ones that are questioned for their credibility and their ability to be able to demonstrate or articulate what happened to them when we're talking about traumatic memories that can be very spotty at best, and children are going to respond to their victimization when they're disclosing or reliving what has happened in a myriad of ways that don't always meet the expectations of the investigators involved.
I definitely can see that. One last question from me, Dr. Kavanaugh. How old was Timmy?
Timmy is now 15 years old.
And how old was he when this occurred?
14.
14.
So it's been a little over a year. He disclosed March 2024. Yeah.
Okay. All right. I'm sorry, Representative Edmiston.
Oh, thank you, Madam Chair. Thank you both. Dr. Kavanaugh, thank you so much. You framed this in a way that I think we can all understand what you were trying to express. And it's disheartening, I know, to everybody here. I'm so frustrated. There's so much bureaucracy. I'm sorry. There just is. I mean, we just can't get to exactly what we need to do for children. Children are the last ones that get the care that they need because of so many different things. Communication, that's another thing. I mean, where is common sense on communicating with each other when it comes to children? So if there is something that is keeping us from doing that, I would like to work on legislation to change that because this is ridiculous. Absolutely. And if Timmy would be the only child, that would be one thing. But I worked in a school system for 22 years advocating for children and families between schools and home. Mm-hmm. And I can tell you right now, this goes on all the time. And it's us that keeps it from being solved. The things that we do. So I appreciate your recommendations. I appreciate the chair saying that, you know, we're going to look at those because we are. And I know there's something that we can do to change this. The child advocacy centers, I should know about those with all of the work that I've done in my life, and I don't think people are that aware. Who can refer to a child advocacy center, or can you?
Yes, ma'am. Thank you for asking. And we do have the president of the state, the executive director of the state.
Okay.
There are 14 CACs across the state of Louisiana currently at varying levels of accreditation with the National Children's Alliance out of Washington, D.C.
Okay.
Representative Edmiston, they are coming up next.
Okay, good.
And so we have the chair here, and then we have multiple CAC throughout the state who's going to talk about their processes.
Good.
And so this is going to be really good for us. But you bring up a good point because before I was elected, I did not know about them, and the only reason why I became to know about them is because I was on finance, and every time they would come to the finance committee, they were always asking us not to cut their funding, which is a whole nother issue that we need to talk about, because when we talk about trying to get to this most vulnerable population, we got to make sure that we are funding and making sure that they have what they need to be able to render the services that are needed.
That's right.
And I'm going to tell you, the last hearing I was in, which was this year, I was there when y'all came to the table, and not many of my colleagues were even there. And I'm not trying to point anything out about anybody, but when we talk about these issues that affect our children, it's all together. It's all woven together. We can't pick and choose which part of it we want to do or not do. It's all together. And in order to ensure that our kids are more safer, because right now I don't feel that they are. I'm telling you, I am so frustrated and I'm so angry. I do not know what to do. I really am. I'm angry with how things are being done. The bureaucracy, you hit the nail on the head because it's too much. It should be much more simpler.
Yep.
And it should not be on the child. So I don't want to get on my little tangent because I am, but I'm just going back. I was there. You guys came, and I think we actually gave what you guys requested. But at the end of the day, I've been on finance 8 years, and I've been coming to the committee hearings even when I wasn't. And every year y'all have to come and beg for money. And that should not be. I'm telling y'all right now. I'm telling my colleagues right now, that should not be. And so anyway, I'm a move from that, and we need to make it simpler.
Can I have
If I
one
may,
more question?
Your answer to that, depending on the Children's Advocacy Center and their multidisciplinary team or the area that they serve, the referrals will primarily come through law enforcement or child protection. For some centers, it will require law enforcement and child protection. Because of the example of what Dr. Kavanaugh gave, that was one of the reasons that we amended our protocol to allow for child protection to be able to bring them in, regardless of whether or not law enforcement became available. And then if a child does disclose in that forensic interview, we are sharing that information with law enforcement, but at the end of the day, it will be up to their discretion as to whether or not they accept.
One more question, Senator Barrow.
No, go ahead and ask the
Whenever
question, because
you're
that's a
ready.
whole nother issue.
Really a question, it's a comment. I'm so tired of hearing, well, we don't know if that's really true. We don't know if that child, and I loved what you said, Dr. Kavanaugh. How in the world can someone program a child to say all of that? That doesn't happen. I'm tired of that. I'm just really, really sick of hearing that. We should believe the child, and then if we find out that the child is not telling the truth or is in error, then we can do something about it. But whoever said defer to the child first, that's exactly what we need to do. I've heard that for years, and it rattles me, as you can tell.
And I'll say that in part, I think that is just psychologically due to not having the right training, because it is so painful to imagine that this really happened. It's so much easier to say, well, that mom just made it up. She wanted to sue the school system, or that it's so much to take this in, you know?
That's not a good enough excuse for me. I'm sorry. It's just not. And I don't mean to be rude. I'm like.
Not that it's an excuse,
Senator
but
Barra,
like, I do think that education could help make that
we could.
assumption, help people realize that that is a myth. You know,
It is
that's
a
not the
myth.
reality of the situation
Yes.
in the vast majority of cases.
Yeah.
And if I may, depending on the center and the multidisciplinary team, there are some centers that have multidisciplinary teams that are exemplary in their functioning, and they truly do take into account the entire team's perspectives. Unfortunately, that is not the case for all. There is not a consistency across the board.
Thank you both so much. Thank you, Madam Chair.
Thank you so much, Representative Emerson. I'm so glad to have you two ladies here today serving with us on the task force. So let me see. Oh, Ms. Moody.
Yes, ma'am. Thank you, Dr. Kavanaugh, for being here. I have a question about the letters, and if I was following you correctly, you received 2 separate response letters from DCFS.
You know, I only found one scanned in the chart. It's possible. I think I only did get one, actually, because my reports were within 24 hours of each other.
And so one of the challenges here is that it wasn't clear to you as the reporter that your information was not passed on to law enforcement. So I guess my question to my colleagues, is that a simple fix in letting the reporter know in the letter that their information was not passed along?
Put us all on again, please. Thank you.
We have made some recent changes to our notification letter, and so that is probably something that we could make some additional changes to make it more clear to the reporter, because I agree that is something that I wouldn't know if I wasn't working for the agency. I would have no idea that DCFS could not share that information with law enforcement.
Yeah, I think that it's kind of like legal jargon here, but these, you know, we're just regular people trying to protect kids. If it could just be straightforward, that would help.
I agree with you 100%.
And that's one of the reasons that we always recommend dual reporting, because we know that in some instances, while child protection may not be able to accept a case, law enforcement may, and vice versa. And the protocols do have to outline a sharing of information response and whether or not they're in compliance with that. But again, it really just does depend on whether or not they are going to accept it and when they do share that information.
Okay, very good question. And so this is something we feel that we can do readily, quickly? Okay.
Brett's Assistant Secretary Hanneman is saying yes.
Yes,
so
okay.
I'm going to defer to him on that.
Because we would like to have that implemented immediately. Okay. Mr. Payat?
Thank you for your comment, Ms. Dupape. I can certainly appreciate the comment about submitting reports to the district attorney's office. That's a tool that law enforcement has. That's a tool that detectives, troopers, and investigators in state police routinely use and have to use. And perhaps maybe it's just we have a very strong district attorneys association. We have very strong sheriff's association and chiefs association, and maybe we just need a little more collaboration and conversation and ensuring that officers know they have, and supervisors know that they have that option and to use that option. So thank you.
Thank you.
Thank you. Ms. Shelton.
I know you can't give specifics about any case, but the hypothetical Timmy in that situation, what kind of services or referrals would the CAC give? And then I also had a question, and I know this might be CAC related, but you're sitting there and we're talking about this case. In that situation where he's seeing a therapist and she understands how to communicate with a child with special needs, would the CAC communicate with that therapist on a way that, you know, this is how Timmy communicates, this is puppets, or this is, he's very verbal in this way, but not this? Is that something that would be done prior to interviewing that child?
If that is made available, yes, but as was mentioned prior, if child protection is the primary or initiating response, they cannot share with us who made the report. And so it would be at the discretion of a caregiver or someone else who is caring for the child to be able to share that information on a professional that is working with Timmy. And then we would absolutely want to collaborate or learn more about what would be most effective in helping Timmy move forward. We have victim advocates on staff. We also have licensed clinicians on staff that are trained in trauma-focused mental health practices. And then we also have our board-certified child abuse pediatric doctor on staff. So we're able to provide all services inclusively on site and work collaboratively with any outside providers if presented.
And will you, if you have a child with special needs, will you ask, you said if the caregiver provides the information, would you ask that caregiver prior to the interview, is there someone
Absolutely.
treating this child we could speak to about communicating with them?
Yes, because when a child is being referred for a forensic interview, we will ask if there are any special needs. And if there are special needs, that's where we begin with the questioning of finding next steps to best support the family and the child.
So would it be possible I feel like DCFS should tell law enforcement who reported, because if the doctor has to then report it to the police, it becomes part of the public record anyway. So there's no benefit to like withholding who the reporter is between DCFS and law enforcement. Does that make sense?
Put us all on, and Honorable Womble, and Dr. Hook both want to respond, but we're going to take you first.
It is just on the issue, on the limited issue of DCFS saying who reported. It is actually a misdemeanor if it's a misdemeanor crime if a DCFS worker or says who reported.
To the police?
Yes.
That seems like that doesn't really make sense, does it?
If they release to anybody, they can't even tell me in court. I'm a juvenile court judge, okay? And I cannot discuss a case, a situation here. That would be a judicial canons violation, okay? But just on the issue of when DCFS gets a report, okay, whether it be from whoever, it can be any one of us, they cannot disclose even to me in court, even testifying to me about the case, they cannot disclose who it is. That person can come in there and tell me who it is, but they cannot disclose to anyone, even in their own reports, even in their Form 10s, even in all of their stuff. So that becomes a problem. If they're sending out a letter to somebody, hi, thank you for reporting it, we're taking, and it says whatever it says, I think there's going to be a problem if they start saying, hey, and we told the police that it was you, or anything. That's I think that needs to be looked at before that's added on to a letter. I'm just letting y'all know.
I'm wondering if maybe what we need to add to the letter is a notification to the reporter that we cannot share their information with any outside entity,
Well,
including law enforcement.
I cannot give legal advice. I'm a sitting judge. I cannot give legal advice. I am also in this very unusual, uncomfortable predicament right now where I cannot discuss I cannot discuss a case either. So I'm just saying, the fact is, anytime DCFS gets a report, they cannot disclose who the reporter is. The law is written to be an anonymous protection, and it does not matter who it is. Now, there are times where I can figure out from the testimony and the evidence presented to me who the reporter is. I mean, it's obvious. But they cannot confirm or say who it is. So there's going to be a problem with DCFS giving the names of the doctor. And sometimes the doctors, I don't think, want anybody to know who it is in order to maintain their relationship or with everybody. So I'm just saying this is not a very easy solution.
So to me, therein lies another issue or a problem because, so for I'm gonna say law enforcement, where we already know that the resources are already restricted and time, etc. If they got to go and try to figure out and search, right, where to start even on a case, I mean, how do they have the information they need to even get started? So do they go back and call DCFS?
Well, the police are, I don't know, they're going to talk to DCFS, but I don't know what DCFS exactly gives them or anything. All I know is what I get in court, So I'm just saying, I know that they are not allowed to disclose it. And there's a reason for that. The law was written with the idea to protect people and to encourage people to make anonymous reports.
And it's a safety issue for the report, like the person.
I get that part. I do, and I understand that.
So want to keep them safe.
So maybe that needs to be looked at. If somebody wants to go, hey, I'm available, I'll tell everybody, public, private, whoever, that it's me. But I mean, there are laws that specifically protect it. So it is not just something that I would feel comfortable with them adding to a letter or anything. I mean, there might be some doctors who would be very upset to get a letter. Oh yeah, we gave the police your number. We told them it was you. Because now that police report is going to be public, more public record than the DCFS reports. Okay, and there are DCFS reports. There are a multitude of reports that have to go out. Form 10s, I'm just thinking, and it will say, Form 10s, I've read, I've dealt with over 1,000 child in need of care cases while, as a public defender, and then, continued on the bench. And, but they do not say who the reporter is, and they're not supposed to say who the reporter is.
Well, and I just want to say that, I was also that doctor that was like, I don't want them to know my name.
Yeah.
But then I didn't know that I legally had to report to the police.
Right.
I had no idea. And most doctors here in this country don't know that.
And I used to, now I cannot give legal advice because I'm on the bench, but as in my practice, I got phone calls routinely from doctor friends of mine, including my children's own doctors on occasion, asking me, about the process, how to report, when do I have to report, who do I need to report to? And so, and that's pediatricians and, and children,
But it seems like in this case,
know.
the only way to have protected my patient was for me to report and disclose who I am in the public record. That was the only, the way the system is now, that would be the only way to keep Timmy safe, is what I'm hearing. So I feel like you have a big job ahead of you guys to figure out how to fix that. But right now, there is no protecting my name in this case, for example. It has to become public record the way the system is now.
In some cases, that ends up being a deterrent for people to come forward and then make said report.
So then this goes back to what you said, Representative Edmiston. Because how do we just simplify this and make it just much easier, right? Because this is a bunch of BS. I understand the privacy piece. I get it. Because, depending on, whatever, some people, they do not. And I understand that. But how do we simplify this and make it easier? How do we ensure children like Timmy are protected and the person that's seeing him or her feel free to be able to share what has occurred that is wrong? That's simple, right? So we need to figure that out. We need to figure that part out. Dr. Birch.
Thank you.
I think we all
I will second that mandatory reporting, like clarity and the ability to initiate joint investigations would be a great improvement on the ability to help providers navigate how to report. I supervise a team of almost 20 clinicians, and all we do is grief and trauma counseling, including the services at the Jefferson Child Advocacy Center. I think in the time since the last time this group convened, I have probably supervised almost a dozen mandated reports. I have personally made 4 to 5 mandated reports where I've sat on hold with DCFS for 45 to 50 minutes while my clinician, we kind of have a system. They call law enforcement while their supervisor calls DCFS because the process of reporting takes so long and can be so onerous. And we sort of have it down to a system because we do it so frequently. And so I think as a committee, looking at how we accept reports, what joint investigation protocols really look like, because all of my clinicians, like Ms. Dupape said, are reporting to law enforcement and to DCFS. But a lot of times it's us doing the back end runaround, which is why we can't do billable Medicaid services because our clinicians spend so much time making sure that we have the DCFS worker and law enforcement talking to each other throughout the investigative process. And so I think that piece is very important as we look at kind of how we and where we intervene and make recommendations as a committee. But I get calls from colleagues all the time who are not making these reports every day and being like, wait, what do I do? Who do I call? If I call 911, is that good enough? Do I have to call child abuse directly? And sometimes with law enforcement, we'll be like, well, you need to come drive to the parish and come over to the parish and make the report. And I was like, emergency room doctors are not driving over the parish line to go make reports or leaving psychiatry practice to make those reports to law enforcement. And we are able to navigate that because we have relationships with our Child Advocacy Center partners. But I do think how that looks across the state really matters. And as a committee, taking a look at how that procedure works and how joint investigations are initiated. I've worked in 2 other states in Child Advocacy Center settings, and the ability to call to a single entity and initiate joint investigations is a real improvement to kind of this dual requirement, especially when you've got systems that are so overtaxed, law enforcement and DCFS. They are investigating large caseloads and there's such a massive demand on their time.
Thank you. You make a very good point, and I'm looking at a portion of the legislation that we did this year that I thought would kind of clarify it, but as I read it myself again, then it does leave me even kind of questioning, and I'm going to ask you guys how that's working out in a few minutes, but I'm going to go to Dr. St. Germain first.
First of all, I want to say, sit on there, Dr. Kavanaugh, your reputation of stellar psychiatric care precedes you. It's so nice to finally meet you. And of course, Erica, nice to see you again. somebody who's so passionate about taking care of kids. We've seen Timmy before. Timmy comes in a lot of different forms, unfortunately, and I don't want to lose sight of that being a paraprofessional. If they're licensed as a teacher, we've already been through the Department of Education and talked about licensure and them not having any control over someone who is not a licensed teacher in our state. And again, I think we've discussed, principals being responsible to make sure those people are reported. But we know Timmy's abuser went and got another job in less than a couple of days, working with disabled kids. So that's just the scenario that plays over and over and over. I think, as we have heard from the Department of Education, when they're a licensed teacher, they can, create an action plan. But for those who are not licensed and paraprofessionals, or teachers' helpers, or whatever title they get, we have a gap. And I'm not sure how to fix that gap. And then, with my own practice as a forensic nurse and frustration when our team doesn't agree, and we come out being traumatized by that and not really sure how to fix it. And so my solution was to leave my position at the time because of that problem. I just don't feel that law enforcement should be the only naysayer, and then it's like, having an older brother. Oh, they win, they win this. When you've got so many others on the MDT saying the same thing, like, we can't believe, we know kids that don't have the disabilities are not always going to give the same, scenario. So I had a question, Erica, for you. Are the forensic interviewers given special training for children who have other ways to communicate, like using the puppets, which I absolutely love?
Well, thank you, Dr. St. Germain. With respect to the puppets or the drawings, those do require additional training. I currently have 2 brand-new interviewers, and so I've been doing a lot of the interviews, but they are all going through their trainings. And yes, when there are trainings available, there are a number of excellent professionals in the field that are able to provide said trainings on working with children with disabilities or difficulties with verbalization. Yes, though that is absolutely included in their curriculum. But again, until they're at that point, I'm doing those interviews. So.
Thank you so very much. Thank you for the question. Thank you for your response. I don't see any additional questions for you ladies, but I do want to ask a question to DCFS as I'm looking at the legislation from this year on page 24, number 3, when it talks about dual reporting to both departments in a local or state law enforcement agency is permitted. And the new language says, however, the agency who receives a report pursuant to subparagraph 1 or 2 of this paragraph shall be the agency responsible for accepting and acting on the report and shall ensure referrals to other agencies as necessary. Can y'all tell me how this is going so far? This is the new language of the bill.
In the last 2 months,
Yes.
since it's been enacted, I do not have a direct answer for you. I can find out.
Okay.
I will. But I'm
Because
sure- But we've been following that law since it went into place and making sure we've been.
I do know that we had an incident where there were 2 reports that we received for alternative response that were not made in the stated way that was in the act. So we had to kind of work together on the back end, but we have made complete modifications with our team and our system to make sure that that wouldn't happen again. They were accepted, and now we
Okay.
are going to be alternatively responding to those cases. But I think it was kind of people read the act in one way, and because it didn't exactly spell out like that certain mandatory reporters should also be included, those reports got kind of weeded out. They have been weeded back in, and we're addressing them.
Okay.
That was when the program first started.
Yes.
So you know that.
Okay. So for the most part, because as I read this, I was a little concerned that all reports hopefully are coming to you guys, but if they don't, then that becomes my question. Like, so if it goes to law enforcement first, do you guys find out about it and then follow up?
We still don't really have a process in place for us to know if law enforcement is sending us everything that they're receiving. And law enforcement still doesn't have a process in place that I'm aware of for them to know if they are receiving everything that we get, I guess, initially. So that's where potentially some children could fall through the cracks, because we don't have a system, like a statewide system that we're able to exchange that information. We're having to exchange information between local offices across the state.
But that's something that we are working on, right?
I don't know that there is a plan for like a statewide
Is that something that OTS,
OTS.
supposed to be helping us with?
Well, I want you to understand how each one of these different sheriff's department operates. Okay, so we're notifying, but with some we'll close and we can only notify them in the morning. So
Or
can we standardize this process more? Yes, we can going forward.
So that's one of the things that we are going to work on, because we have too much technology to not make this a little bit more parable, where it's paired up. It has to be a way that this can work more succinctly. And I get it. I know about the different times, et cetera, and then the limited resources. But we have too much technology that we can't make this a better, seamless system. We have to figure it out.
I agree.
Yeah, we have to figure it out. Okay, so we're going to take you, Dr. Birch, and then we have lunch for all of our panelists, and I'm going to give everybody else a slight break before we take up our CAC. They're the last part of our discussion today, and then public testimony. So before we do that, but I'm going to let everybody take a small break. If you want to run, go get something, use the restroom, etc., you have an opportunity to do that after Dr. Birch question, and then we'll come back in about 15 to 20 minutes. Okay, Dr. Birch.
To follow up with my DCFS colleagues and just say that in my most recent report, the hotline worker did advise my clinician to call law enforcement, and really reiterated that, like, just by calling DCFS, that wasn't enough, and that law enforcement needed to be notified. So the hotline worker had that information and reiterated to the caller that needed to be done. So, yay. Yes.
Okay. That's good to know. And Honorable Judge Green. There we go.
Can you hear me? Okay.
Yes, you're
So I want to
on.
be very quick. I have the same sentiments as Judge Wobble in regards to how much we can, put in this arena. But I do want to clarify one of the recommendations and what we are able to do. I can only speak for my court and what I do. When I say my court, I'm in family court in East Baton Rouge, and I'm saying in Division B. I'm specifying that because just like law enforcement, I cannot tell you what other courts and judges do. The recommendation was one non-parent consult before removing rights of parents. And I've listened to a lot of the statements, oh, no, this can't be happening. Individuals might not use, in family court, there are instances, a lot of instances where one parent uses this type of sexual abuse allegation against another parent. And they can use the child to get that information out. And so when you guys say, I can't believe it, it's happening. And so when you say, well, you should do this a little different, when I first came to this panel, what I suggested or what I presented was what the family courts, and there's only one family court and one now in Ascension. Everyone else is general jurisdiction. That means that they handle multiple cases, types of cases, and family court is thrown in there. So for family court and EBR, we have domestic violence days and we have emergency custody days. That is typically when we hear, and rule dates, when we hear things like sexual abuse come up. And to say you need to hear all this before, a lot of these individuals get attorneys and many don't. We try to allow pro se litigants the best opportunity to be heard. But if it's a DV matter, it's filed in clerk of court, and then it comes up as on our duty days as just a written pleading. We don't have any facts. I cannot utilize third parties. I cannot. I only get the case, the written fact, and the pleadings, and I make a determination if it reaches the level at that time to be protected, and it's a temporary restraining order, okay? And so, no, I don't have the ability to add a third person before I may remove or tell a father or a mother they can't go back to their home. That's how that starts. Then they come back 2 weeks later and they have the ability to have a hearing. In an emergency custody case, if it's a sexual abuse allegation or a regular abuse allegation, whatever there is brought to us, we can hear that the same day, typically. And again, it's up to the attorneys and the litigants to provide all the evidence, things they need. And sometimes, many times, they don't have any of these reports that you guys are suggesting. Many of times, even if there are medical providers that are part of these cases, they don't want to come to court. If DCFS is involved, I typically pause the case to allow for DCFS to make a determination, the letter that you're addressing. And in custody cases, it may be a reporter from a hospital, a doctor, a mental health provider. But sometimes the report comes from the parent. And so the letter that we're waiting for is only going to come to a person that is being alleged as the offender. The other parent doesn't get it. But I do an order, I just did one this morning, to DCFS to provide me information if it's ongoing. And then I can make a better determination if we can hear the case. Again, that does not mean DCFS is coming. I'm only getting a report. They rarely come to court. So when the statement or the assumptions that all these things are happening and there's an assumption that we should just jump in as judges, like she said, I don't see anything until it comes. And if you don't bring the reports and the evidence to me, I can only utilize what I have. And so, and I'm saying this from the standpoint of someone who has been a child in need of care attorney with Southeast Legal Services, someone who who's on the board for family and counselors. So I listen to a number of counselors over nationally, and someone who goes to many CLEs in regards to abuse, okay? And so I am not coming up with these. I listen to mental health providers often, and I try to understand everyone's tactics and the way they present it. But if the evidence does not come to my court, and even if it's subpoenaed, guess who blocks even if the DCFS worker or said information is subpoenaed, they still file motions to quash. I can't keep saying it enough that you're assuming that we get all the information on the court level that we do not receive. And if I get it, I'm going to use everything that I have. And no, I'm not going to just depend on one third party. If we all come in court, or I let mental health providers come by Zoom. Whoever wants to come, I let you be heard. But I think there is a misconception that when abuse cases come, that the court sees all the things that you are doing. I do not. And so it gives me conflict when I listen to the panels and a lot of the presentations, because it's missing some of the ways that evidence, you're saying, make it simple. You cannot make evidentiary issues simple. And the legal people on the table know that. So they can file anything they want to stop it. They can bring it in if it's different ways that it gets stopped, but it's not make it simple or require DCFS to come. Y'all already required it. Actually, give them 6 months. You give them 6 months to investigate. So no, it's not quick. That's your law. That's the law that you guys created. Mm-hmm. So there are other ways that I think maybe for mental health providers is you utilize the associations that you have to make some more provisions in or require 18 hours of CLEs. They're requiring us to do a lot of CLEs or CEUs or whatever they call it on specific topics. I do believe we need specific topic, especially because, again, a lot of the judges that are hearing these things are general jurisdiction judges, and they are overwhelmed. They have civil, criminal, adoptions. I just have family court. So that's why I hear it and I'm like, hold on. But overall, this is needed, but we can't just keep saying simple because the law is not simple. It's nuanced. It's fact-based. And again, this is a fact-based state. So you can come in with any facts that you have. You have the evidence to support it. And sometimes that is left out of the conversation. And so I hope that is cleared up in this discussion. We take a break. I'm happy to discuss, but I also just want it to be known that adding a third party to a litigation for family cases, that's your witness. So it's up to the parties to bring that third party in or to to have the judge hear that person as a witness or as it would be a witness. That's the only way you can get in. So I understand. Again, I worked in juvenile court with Ms. Shelton for years. So I get it. And I was the defense attorney. So I understand that. And so we just assume we get on these benches and we're judges and we don't understand anymore. We actually understand even more because we see it every day. So hopefully that helps you get a better picture from the parental side of it. But again, it only will come to me through a rule date, through a ex parte emergency custody matter, or do domestic violence. And we have actually contracted IRIS Domestic Violence. So I don't even see half of them. IRIS Domestic Violence Center has their own attorneys, and their attorneys handle those cases, and then they bring them to us afterwards if they want to proceed on a hearing. So hope that helps.
Well, I will say I appreciate the both of you kind of sharing some of the nuances and what the law actually speaks to in terms of how things have to be done. I absolutely do appreciate that. And I thank y'all for sharing that. And that's why it was so important to have you guys a part of the task force so that as we are looking how we pare down, how we actually make this more of a seamless process, we can have the expertise of you guys at the table. However, I do believe that there's still some gaps that can be filled with simple things that I think technology can help us with, which I'm hoping that we can kind of get to that as well. But I do understand that certainly I understand you can't rule on what you don't see, what you don't read, and what's not made available to you. I absolutely understand that. And so we need to figure out how do we do that? I mean, you sound like you just said that sound like you said IRIS is now doing their own domestic violence, which we're not dealing with that. You know, we're not dealing.
We also have STAR.
Okay.
Sexual traumas.
So you say they bring in their own attorneys, right?
We have contracted with them, so they come in on our domestic violence, and they're the attorney.
Wait a minute, let me make sure you're on.
Oh, I'm sorry. We contracted with them, and they become the attorneys on the cases that are domestic violence, including sexual assault. But if it's sexual assault, sometimes they refer to STAR, who also has
okay.
attorneys. So what we're in fact doing is providing litigants attorneys so that they can be fully represented.
And have better representation.
Yeah.
Okay. Well, when you say IRIS, I thought you were talking about domestic violence. But anyway, nevertheless, I'm glad to hear that as we're trying to make this a better process. When I asked the question 2 years ago to Judge Ritchie regarding a case that was brought to my attention, which was not the first case I heard, that's how this whole task force got started. Because we recognize that it is a very cumbersome process. That's why we actually established the task force. But let me tell you what I am not going to be for. I am not going to be for just kind of passing on the buck and continuing to do things as we've been accustomed to doing. If we need to change the law, we're going to change the law. If we need to figure out a way of how we streamline the process, we're going to streamline the process. What I am not going to allow, at least while I'm elected, is to allow the victimization of children to continue in this state. Not under my watch. When we can, you're right. We've seen Timmy a lot of times. So it's time for us to stop seeing Timmy. We got to do something different because what we've been doing is not working. That's what I do know. So I am for doing whatever it takes to make it better for children. And that's period. Period. And whatever it takes, that's what I'm prepared to do. And I believe we have a great team established here to do the same thing. So what we're going to do now, we're going to take a 15 to 20-minute break so everybody can go use the restroom, grab you something to eat if you like, right, real quickly. And we're going to come back. And these are the people who have asked to speak, so be prepared. Erica. Okay, so you already, all right. Crystal Mitchell. Morgan Lamondre, and then we have a lot of people here from the CACs who have said that they're here to provide any testimony if needed. Then we have Mr. Ducote, Attorney Ducote, and Catherine Diamond, and Micaiah Rogers, and Lynn Abertrit. I'm sorry? Albert. Okay, so when we come back, we're going to hear from the CACs first, and then we'll take our public testimony. So we'll be back. Let me see what time it is. It is 2:10. We'll be back at 2:30, and I'm going to try to keep this meeting to no more than 2 more hours, okay? All right.